Good afternoon and welcome to the June P&T meeting for the Oregon Health Authority. This meeting is being recorded, just to let you all know. We're still waiting for one of our committee members so that we have a quorum so that we're able to conduct business. But for your information, the P&T committee also serves as a DUR board, and those are required to be held. DUR board meetings are required to be held quarterly. So this is one of those meetings that's focused on those efforts. The first probably half of our agenda is DUR focused. So I propose that we proceed. One of the things that we do at the top of the order is ask for the committee to approve the minutes from the prior meeting. Again, I'd like to have a quorum before we ask for any recommendations or approval for those. But we're reaching out on multiple channels to get the last committee member to join us so that we have that quorum. Nonetheless, I want to take the opportunity and respect you all to get going. So with that, we're going to start off with roll call and introductions. And so on the screen, you'll have in front of you the P&T committee members that have been appointed. They're appointed for 3-year terms. I'd like to draw all of your attention to that last line. We need a physician, an MD or a DO that's actively practicing in Oregon to be appointed to the vacancy. We also have another member that's willing to continue until we find their replacement. But again, if anybody in the audience is aware of any, again, MDs or DOs actively in practice in Oregon that appreciate evidence-based medicine and would like to lend their voice to recommendations to the Oregon Health Authority, please ask them to consider reaching out to myself or Trevor Douglas so that we can talk to them about the requirements and what it takes to be a member and be considered for appointment to this committee. So with that, we'll go to the committee members. Pat and Kat are not joining us today. Stacy, we'll lead off with you.
Hi, everybody. I'm Stacy Ramirez. I am faculty at Oregon State University College of Pharmacy and a clinical pharmacist and director of pharmacy for the community health centers of Benton and Lynn counties.
Thank you, Stacy. Tim isn't able to join us today. Karen?
Hi, this is Karen Michelson. I'm the pharmacy director for the Copical Indian tribe located in Coos Bay, Oregon.
Appreciating you being able to get it today. Thank you, Karen. Robin?
I'm Robin Moody with the nonprofit Dental 3, public member of the P&T.
Thank you, Robin. Bill isn't able to join us, but hopefully has spectacular pictures to share upon his return. Mark, how about you?
This is Mark Helm. I'm a general pediatrician at Small Town Pediatrics in Silverton, Oregon, and I am a P&T committee member.
Thank you for making the time, Mark. Russ?
Hey, I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Again, welcome, Russ. And Eddie won't be joining us today. So again, waiting for one more committee member. We'll also do introductions for staff. Jennifer will lead off.
Jennifer Bowen, Executive Support Specialist with the Oregon Health Authority.
Thank you, Jennifer. Roger Citron, Director of the Drug Use Research and Management Program. We provide clinical support for the OHA to administer these P&T meetings and provide oversight and help with coverage of medications through the pharmacy benefit. Trevor? I see you're unmuted on our screen. You might have a second mute going on your side, Trev.
Trevor Douglas, OHA Pharmacy Director.
I'm Dave Engen, a clinical pharmacist with the OSU Derm team.
Sarah, I see you were able to join us. Sarah Fletcher, are you able to unmute?
Oh, sorry, I unmuted and didn't unmute. I'm Sarah Fletcher. I'm one of the P&T co-coordinators for the Derm team.
Andrew Gibler, Clinical Pharmacy Manager at OHA.
I'm Kyle Hamilton. I'm the Pharmacy Drug Coordinator with the Oregon Health Authority.
I'm Megan Herring, a clinical pharmacist with Derm and faculty with the OSU College of Pharmacy.
Good afternoon. My name is Deanna Moretz. I'm a pharmacist with the OSU Derm team.
I don't think Amanda was able to join us today. Kathy?
Sure, I'm Kathy Santana, and I am also a clinical pharmacist with the OSU Derm team.
Hi, my name is Sarah Servid. I work with Sarah Fletcher as a PNT clinical coordinator, also with the Derm group.
I'm Lance Starkweather. I'm the pharmacy manager for Gainwell Technologies.
Dee wasn't able to join us today, so we'll turn it to Brandon.
Hello, Brandon Wells. I'm the pharmacy program analyst for fee-for-service for OHA. Thank you.
Afternoon, I'm Gary Kurgowski. I'm a second-year pharmacy resident at the OHSU Richmond Clinic in Southeast Portland.
Excellent. Thanks for joining us, Gary. Okay, we have the approval of the agenda. Again, the agenda is in front of you. We don't propose any changes. Might have some sidebars with my team depending upon whether or not we have a committee member, if we're going to adjust topics for which we might not be making any recommendations to the OHA. But at this point, we'll proceed with the agenda as included. For the committee, for the public that is listening, just wanted to say that the packet of materials, this agenda that we'll be going through today, is posted to our website. So you're probably already familiar with that website. It's where you sign up for public comment, where we post draft materials to solicit comments before their final posting. So again, that packet of materials and written testimony that's been submitted for the consideration by the committee is also posted out there. So if you want to follow along, we'll draw your attention to that throughout the meeting. Conflict of interest declaration. So conflict of interest is vitally important to this process and to the OHA in general. All of my staff and all of the members of the OHA have conflict of interest declarations on file with the OHA. And the committee members are all required to fill out an extensive conflict of interest declaration, as well as the public if they're wishing to provide public comment on our draft materials or provide public comment during this meeting. So again, full transparency, if any committee members have a new conflict that they need to disclose, we provide an opportunity now. We expect that those are updated as needed with the OHA. And if there's any topics that come in front of the committee for which the committee member feels that they have a conflict, we just ask that they recuse themselves and abstain from voting. So with that, are there any conflicts of interest that are new that anybody needs to disclose? Excellent, as expected, hearing none. We usually do the approval of the minutes, which I'd sent out to the committee in advance for review. But before we do approval of minutes, I guess I'll just simply ask, no, let's move on from that. So we'll move on to Andrew Gibler and the department update.
Thank you, Roger. This is Andrew. I just want to thank all of you on the committee for again joining us and your engagement and commitment to the committee and the work that Durham produces. I just want to highlight some recent approvals of and work from the Mental Health Clinical Advisory Group, which is an advisory group to the P&T committee. And they approved some documents I wanted everyone just to be aware of. You can find their website on the OHA by just typing in Mental Health Clinical Advisory Group. They on the right of their webpage there, you can see where all their recommendations and guidelines are. They produced some documents around benzodiazepines, a patient-facing document for in plain language that allows individuals to learn about their benzodiazepines and the benefits of tapering off and other support that's available for anxiety. And then there's some clinician-facing documents. One is a document about how to talk to patients about their benzodiazepines and willingness and collaboration to taper off of those. And the other document they approved is how to taper benzodiazepines. We also will be developing plain language summaries for all mental health clinical advisory group documents so that everyone has a chance to at least be able to understand briefly what is recommended in their documents, and as well as some language supports for those documents. And we've been in discussions with the Derm team as well, as we know their documents are geared for you, but in an effort to be transparent, we would like to start developing some plain language summaries of what the P&T committee decided, so that that's available to the public and they understand what you approved and why you did. And I think that would be helpful in our effort to be transparent in all of our work. And so with that, I think that's all I have, Roger, and I'll kick it back to you, unless there are any questions.
I appreciate it. Yeah, exactly. Want to see there's an opportunity here. We're not in a rush. So any questions for Andrew?
Hi, this is Karen, and I was wondering, Andrew, if it might be possible to have the patient and provider facing documents on the benzodiazepine tapers shared with the P&T committee via email.
Yes, I'd be happy to do that.
Thank you so much. And thank you for all your hard work on those.
Any other questions for Andrew? Or more broadly for the OHA, we do have the luxury of having Trevor with us today. So if you had questions that rose to his level. All right, hearing none, we do have a section of the this agenda. That's our consent agenda. So we don't go through these portions in detail. It's expected that the members have a chance to look through them, and if they wish, they can ask to be pulled off the consent agenda and discussed. But they include our quarterly utilization reports. They're also called our DUR reports, which are posted to our website. Just track information over time. One point there is that they're looking back 6 months, just because a lot of the information is encounter data from our CCOs. Included that we do scans of topics where there's not only new information, but where we're going to go review those topics in exec session to consider PDL recommendations. And the final two portions of the consent agenda are some standing topics: our oncology prior authorization update found on page 18, and our orphan drug policy updates found on page 25. And those reflect new agents that have come to market or new indications for agents that are added to these policies. So as I mentioned at the top of the order, our P&T committee does also serve as a federally mandated DUR board. And with that, the DUR rules, the Social Security Act requires that the DUR board meet quarterly. So we have aligned our meetings so that we satisfy that requirement. So not only do we have these utilization reports, but we have our prospective, retrospective, and education. So draw your attention to page 33 if you're following along on the packet. And I'll turn it over to Lan Starkweather with Gainwell to do the Prodir report.
Thank you, Roger. So the Prodir is the prospective DUR that evaluates the patient's planned therapy before the medication is dispensed. This process allows the pharmacist to identify and resolve problems before the patient receives the medication. So the Prodir relies on computerized algorithm to perform the necessary checks to identify problems such as potential and adverse effects, therapeutic duplication, drug-disease interactions and contraindications, drug-drug interaction, drug and patient precautions due to age, allergies, gender, pregnancy, etc. So there are 9 different Prodir alerts that the system reviews. For the first quarter of 2022, we had over 148,000 total. 7 of these alerts are set to pay the claim, while 2 are set to deny. The 2 that are set to deny and require a pharmacist intervention are highlighted in yellow. This is the early refill as well as the pregnancy drug interaction. There was a total of over 96,000 early refill alerts for the quarter, of which over 17,000 were overridden. So that equates to about an 18.3% override. For pregnancy drug interaction, we had a total of 19 for the quarter and only 14 were overridden. Next slide, please. So this next slide just shows the top drugs enforced in the early refill alerts. The number of these are primarily in the standard therapeutic class 711 or the mental health drugs. And the class with the highest number of alerts, which is typical for what we see for fee-for-service, is the SSRIs, antidepressants. So you have your sertraline, fluoxetine, escitalopram, followed by your other antidepressants such as trazodone, duloxetine, and bupropion. The class with the actual highest number of overrides is the second generation antipsychotics, and these are the quetiapine, olanzapine, risperidone, and aripiprazole. And then I've also included in this list of drugs is the medication-assisted treatment drug Suboxone for substance use disorder. Next slide, please. So this third slide just shows a breakdown of the different reason codes for the override. Over about 2/3 of the override is due to medical necessity, followed by submission clarification code of change in therapy, which is 18.5%. Then the last slide just shows the cost savings report for the Prodir alerts. So these are alerts that came onto the system and the medication was not dispensed, providing savings to the state. For the month of January, we had a total of 7 alerts and 131 prescriptions that were not dispensed. So this is over $25,000 in cost savings. For February, we had 5 different alerts, 53 prescription total not dispensed, so over $14,000 in cost savings. And then finally for March, we had 9 different alerts and 158 prescriptions that were not dispensed. So overall for the quarter, it was $67,813.32 cost savings. Any questions?
Hey, Lan, this is Stacy. I actually do have a question. Could you go back one slide?
Sure.
Oh, no, sorry. Go back to the list of drugs that were overridden. How is this organized?
So this is just organized based on what was brought into our system. Okay. I should have organized it a little better, showing at least the number of alerts, or sorted a little better.
Okay, I just was like, I was looking to try and figure out what order it was in. Okay. So yeah, I mean, next time, if at all possible, like by the number of alerts, that would be awesome. Okay, thank you so much.
I can definitely do that. Thank you for the feedback.
Good job, Lan. Any other questions on the Prodir section? All right. After Prodir is retrospective DUR or RetroDUR. Page 37 in the packet is where we've included those materials, and we'll turn it over to Dave Engen.
All right, thank you, Roger. Yeah, so page 37, we're now reviewing Q2 data, so make sure you pay attention to that column. It's a snapshot in time regarding what we're doing in the RetroDUR space, and as you know, these numbers are cumulative. So they increase over time, and we keep track of that and then report it to you. We recently added a change form initiative for aripiprazole tabs, and so for a more cost-effective formulation there. And so we've notified prescribers of the potential to switch, and we're getting a fair amount of uptick on that, just on the small amount that are identified, but still significant savings there. Also, healthy proportion of prescriber switches the more cost-effective form of desvenlafaxine. You can see the numbers there. And we're still finding opportunity with venlafaxine formulation switches. About half the prescribers are switching, and we're keeping track of those savings as well. So on the next page, we've got dose consolidation. This is, we have more there are fewer prescribers being identified with this Retrodur dose consolidation because now we have a lot of the messaging going on at point of sale now, but still we reach out to those prescribers when there's an opportunity and ask that they would switch to more cost-effective consolidation. So yeah, next page is our expert consultation referrals. And this is for long-term antipsychotic use in children. And after we identify them, those that already have a PA or written for short-term use are typically, those are disregarded. And then, but those that rise to a level of needing a referral, we refer those to our OP specialists. So those are the numbers there. If you look at the next page, it is non-adherence messaging. These messages go out to prescribers for their patients on stable antipsychotic therapy, but then we see a gap in their medication refills after 14 days. So they're the numbers for you there. There are fewer patients identified this quarter compared to last, which is a positive sign the message is getting out there. Almost half those patients ended up with a claim for the antipsychotic or a different one in the next 90 days after the prescriber was notified. So both of those are good things. The next page, we've got our profile reviews. The first few are for children in foster care, and we generate profiles for the OHA and they're passed along DHS and then to OP-K for review if needed. You can see the other high-risk patient profiles we review, trying to ensure appropriate therapies taking place. So the prescribers are notified if there's a potential issue. See the numbers for those respective categories there. Yeah, we can move on to the next page, page 42, I believe. We have our safety initiatives, either to alert prescribers to maybe dangerous drug combination or let them know a PA was denied and there's no follow-up therapy noted in the claims data. So here there appears to be fewer patients getting denied claim for opioid sedative combo with no subsequent PA. Along with a higher proportion of patients actually discontinuing therapy. So those are both good trends. Going down a little bit on the list, there appears to be fewer denied fee-for-service antipsychotic claims due to dose consolidation. And the total number of patients without a paid claim within the 14 days is also lower as well. We have the ICS LAVA safety net initiative. We'll be retiring that soon if the committee agrees to that, since there's so few patients meeting criteria at this point. So more to come on that, but oncology denials, we're seeing very few oncology denials with no follow-up claims, so that's good as well. The last page, those are the TCA denials with no follow-up. We're seeing slightly more patients identified than last time, but also more prescribers actually notified as well. So we're getting the message out there, and usually that's handled oftentimes at the pharmacy level, but there's kind of like an extra layer of protection, I guess. So all in all, these are a lot of positive trends. We're confident that these are moving in the right direction, and so we're really thankful for your input, all the members of the P&T committee. We're looking forward to hearing any new ideas or perspectives that you have, so we can keep making significant progress in this Retrodur. So thank you, and take any questions if you have them.
Hey, this is Russ. I have one. So I have been on the receiving end of the desvenlafaxine DUR a couple of times, and both times it was because the pharmacy filled a form. I ordered Prestige desvenlafaxine succinate, and then they filled Cadesla, which is just desvenlafaxine. And so on the one hand, it was kind of cool because it actually served as an alert to me to call the pharmacy and let them know that they'd filled the wrong product. But I mean, I also feel like it's, I mean, I'm wondering if perhaps there isn't possibility for outreach on that end of things as well. And I mean, because I can virtually guarantee you that, I mean, nobody prescribes Tesla. And I know, I mean, even, you know, at Salem Health, like Epic at one point, you know, when you typed in Prestige, it just said desvenlafaxine, but we have since gotten that cleared up. So now it always says desvenlafaxine succinate. So, I mean, there's, you know, all sorts of ways in which the confusion can be propagated, but I mean, at least in my two cases that I can recall, I mean, the prescription was for desvenlafaxine succinate, but was filled for just for Cadesla. So I'm just wondering if there's any ability to outreach to pharmacies to make sure they're aware of the issue.
Yeah, I mean, that's great feedback. We can definitely look into ways that we can get that message out there. You know, chances are with you having a couple incidents, that's magnified over, you know, the many that are out there. So yeah, thank you for that feedback, and we will definitely look into that. And yeah.
I think what I heard from you say, Russ, is we're not able to track if the pharmacy fills the wrong drug. We can only see what they submit in the claim. So I'm glad you were notified and could address the error, but it's not something I think that we would be able to identify on our side. So it's interesting.
Yeah, I mean, that was kind of my concern, and so I mean, I'm not really sure, I mean, how to address it. I mean, other than, I don't know, a newsletter or, you know, something. I mean, it's a little bit short for a newsletter, but yeah, I mean, and it's such an easy mistake to make though, because I mean, they're both desvenlafaxine extended release, and you know, I certainly don't expect every, you know, pharmacy tech, you know, or even pharmacist to know, you know, the ins and outs of, you know, SNRIs and that there are 2 desvenlafaxines, you know, approved. So I'm not really sure how to fix the issue, but I mean, I take care of it on my end. I just hate getting those DURs.
Yeah, no, great point. And again, it doesn't lend itself necessarily to a newsletter, but a fax blast is more targeted. We might be able to do that to our pharmacy network to say it's come to our attention, this error has occurred more than once, and make sure that you and your staff are aware, you know, of this issue, and that might serve its purpose as well. So we'll consider that. We'll take that back. So thanks for that feedback.
Yeah, thanks.
Hey, Russ, this is Stacy.
Yeah.
I just had a quick question for you. Did this happen after the Epic fix? Because I know I noticed that same thing, and we purposely do it sometimes so that the pharmacy can dispense whatever for, like I do it most often with insulin glargine. I'll just write insulin glargine so that the pharmacy can dispense either Lantus or Basaglar, depending on which the insurance covers. And so I know oftentimes Epic does just default to that like generic name. So I'm just wondering, after that was fixed, did the errors occur, or was that before it was fixed?
One of them did.
Okay.
And
all right.
And I mean, so the Epic fix actually was done several times. It was fixed and then unfixed and then fixed again. So the first one, I honestly don't know. but the most recent one was, I mean, just very recently. And so, yeah, definitely since the fix.
Okay, all right. That's good information to have. I just wondered if it was, if it was just a random thing, but I'm with you. I'm not sure why we would pick not Prestige generic when we were trying, you know what I mean? Even if it came in generic, even if it just came in as venlafaxine, it'd be weird to not go with the Prestige generic, I think so.
Yeah, and I mean, that's why I've kind of assumed that it's, some sort of, systemic error that, or just kind of, whoever it is that's selecting the medication, just, doesn't know the difference. I don't know. I don't honestly have no idea how pharmacies sell things and whether it's a tech that does it or a pharmacist, yeah, because, and I mean, that's actually how it came up to me was I got a DUR and ages ago and was like, hey, like, and so, and that's what got me on to the people at Salem Health to fix it, to make sure that it did say the succinate. And I mean, I was even going like typing, this is Prestige, like in the comments and, stuff like that to try to work around it. So, I mean, but, so I don't know. I'm not sure exactly how, but I mean, I can definitely see if they're not differentiated in the EHR, how it would be a mistake. But I know at least once that it definitely said succinate.
Yeah, just wonder. Thank you.
Any other questions for Dave? I appreciate the feedback, Russ. All right, I wanted to shift gears. We did have our other committee member was able to join us. Again, the challenges of having physicians and pharmacists be on the committee is that they are actively in practice and they are treating real patients with real needs, and patients come first. But Kat, really appreciate you taking care of your patient first and now being able to join us. So with that, if you could briefly introduce yourself. You should be able to unmute yourself.
Did that work?
There you are.
Okay. Hi, this is Kat Livingston. I'm the medical director of HealthShare. I'm a physician representative, and I so apologize for being late, but I was providing excellent patient care to hospitalized inpatients.
Well, Kat, thank you. You bring us to 6, so we have a quorum so we can conduct business. The one other topic I wanted to bring to everybody's attention was we had the approval of the minutes from the April P&T meeting. I did send that out to the committee in advance so that you had a chance to review. Does anybody have any edits for us? And if not, I'm going to entertain a motion to approve the minutes.
So moved.
Second.
All those in favor?
Aye.
Aye.
Opposed?
Aye.
Abstain? All right, thanks, everybody.
I will abstain because I was not there.
Oh, okay.
Awesome.
All right.
All right, we'll continue on with the DUR activities. Draw your attention to page 47. 44 and 47 in the packet. One of the DUR requirements under the Social Security Act is education. And one of the ways we do that is through our newsletters, and Kathy Centeno is our editor. So turn it over to you, Kathy.
Great, thanks, Roger. So today I'll be recapping a couple newsletters that were published late last year. The first one was the use of PEP and PrEP for HIV, and this was the topic of the December newsletter. There's good guidance in there on when to initiate both pre-exposure as well as post-exposure regimens. And then the second newsletter was on therapeutics used for treating as well as preventing COVID-19 infection. And there's a really good discussion on the use of monoclonal antibodies for treating mild to moderate COVID, as well for post-exposure prophylaxis. I just want to give a quick thanks to all the authors who assist in providing these important provider education pieces and their willingness to write the newsletters. And we continue to send the newsletter drafts to the committee for feedback, and your suggestions and comments are very helpful. So thank you for that. The next newsletter was just recently published, and it's on migraine preventative treatment. So I encourage you to take a look at that. And then at this time, I'd like to solicit the committee for any topics they think might be of interest to our providers. And you can always email ideas as well. And then you can sign up on our website to receive the newsletters electronically if you don't already do so. So feel free to take a look at that to get these in your inbox.
Good job, Kathy. Again, any subjects come up, or if you think something is worthy of a newsletter, you know, we have this opportunity to hear from you, but please bring it to our attention and we'll banter about as a team and try to schedule that, find someone to write it and put those out. So yeah, always looking for good ideas for these newsletters. Publish about 9 of them a year, so they're quite useful. All right, with that, we're going to start with our DUR new business. Going to turn it over to Sarah Servid and direct your attention to, I think it's page 50 in the packet.
Thank you. And I am going to be presenting today a policy evaluation on sublingual buprenorphine. So the purpose of this policy evaluation is to look at trends in utilization of sublingual buprenorphine since removal of the PA criteria. So our current fee-for-service policy is that we essentially have open access to sublingual buprenorphine, especially during the first 30 days of medication-assisted treatment. And even beyond 30 days in fee-for-service, we don't require PA for most products. We do still have a quantity limit of 24 milligrams per day. So anything beyond that will require prior authorization, but anything below that for sublingual buprenorphine doesn't require prior authorization. And so the main things that we were looking at with this policy evaluation were to look at whether there was changes in off-label prescribing for sublingual buprenorphine, whether there have been any changes in duration of treatment for patients, and whether there have been any changes in polypharmacy or other medications prescribed in combination with buprenorphine. So in order to answer these 3 questions, we identified slightly different populations for each question. And so here we've outlined the basic populations and inclusion criteria for each of these questions. Patients were included if they had at least 1 paid fee-for-service claim for sublingual buprenorphine in the evaluation window that we were looking for. And that evaluation window is listed here in this first row. And so for the questions of indication, we were looking for a 6-month period before and after the policy evaluation. So before and after the removal of the PA. We required a 6-month baseline period in order to accurately identify diagnosis based on medical claims. We didn't have a minimum follow-up period. We're looking for all patients that had a paid claim for sublingual buprenorphine, and our main outcome there was proportion of patients with a diagnosis of opioid use disorder. The methods that we used for looking at duration of therapy were pretty similar in that we were looking at a 6-month window of patients who had claims within that window. We required a 30-day minimum baseline period, no minimum follow-up period, and we were mostly identifying treatment-naive patients, so patients who didn't have prior therapy for buprenorphine. And for that, the main outcome was time to treatment discontinuation. And then in order to answer the question of combination therapy with buprenorphine, we looked at a shorter window, so a 1-month period before and after the policy evaluation. And we're mostly looking for overlapping therapy, so claims in the previous 35 days or following 35 days from a buprenorphine claim. And then again, the main outcome was polypharmacy associated with controlled substances or a few other drugs of interest. The basic exclusion criteria were used for all 3 questions. So we excluded patients if they had other insurance, since claims data for those populations is often incomplete. We also excluded patients that didn't have continuous Medicaid eligibility in the baseline and follow-up periods, where that was relevant, and then also excluded patients that were in both the control and intervention groups. So this shows the basic demographics of the population that we had identified, and these numbers are from the population of patients for the question of patients who had a diagnosis of opioid use disorder, but these demographics were pretty similar across all of the 3 different populations. About half of the people were female. There's a pretty large proportion of young adults. About 60% were less than 35 years of age. The largest racial groups represented included patients identifying as white and American Indian and Alaskan Native, and that's pretty common with the fee-for-service population, just because of how patients are enrolled in CCOs. Comorbidity indexes were pretty similar in the before and after groups for all the populations. And then looking at our first outcome of how many patients had a diagnosis of opioid use disorder in medical claims. So the total number of patients that we identified with a buprenorphine claim did increase after removal of the PEA, as you would expect. So we identified 364 patients in the group before removal of the PEA and 472 patients in the group after removal of the PEA. There were similar rates of opioid use disorder diagnoses, both before and after removal of the PA. So the highlighted sections here show about 98% of patients with a diagnosis before and 89% of patients with a diagnosis in the before group and 87% of patients in the after group. Similar proportions in patients prescribed buprenorphine naloxone. In patients prescribed buprenorphine monotherapy, the proportion of patients without a diagnosis of opioid use disorder did increase after removal of the PA, but this group does represent overall a small proportion of patients that are prescribed sublingual buprenorphine. When we look at duration of therapy, there was no difference in time to treatment discontinuation before or after removal of the PA. And so here you can see Kaplan-Meier curves, both before and before is represented in red and after is represented in blue on this graph. This analysis was significantly limited by the number of patients that were censored from the analysis prior to experiencing a treatment outcome. So overall, about 40 to 44% of the population were enrolled in a CCO before they discontinued treatment, and they were censored from the analysis when they were enrolled in the CCO because we don't know what would influence treatment duration after that point. And similarly, about 10% lost Medicaid eligibility before they discontinued treatment. And then in patients prescribed sublingual buprenorphine, polypharmacy associated with controlled substance use actually decreased after removal of the PA criteria from about 51% before removal of the criteria to 42% after removal of the PA. Very few patients had claims for 3 or more controlled substances, which overlapped with buprenorphine therapy. And you can see the most commonly prescribed drugs that overlapped with sublingual buprenorphine therapy here, which included anti-epileptic drugs, first-generation antihistamines, muscle relaxants, and second-generation antipsychotics. So just a few limitations. The before and after periods were split with the COVID pandemic. The before period occurred before COVID. After period was in 2020 after the COVID pandemic started. And so it's really unclear how COVID affected these numbers. It's also really unknown. There's a lot of efforts going on around nationally and at a statewide level to expand access to MAT treatment and get patients into treatment. And it's unclear how those efforts would have impacted these utilization trends. We didn't include evaluation of medication-assisted treatment when administered in a clinic setting. And then just a few notes on the polypharmacy data. We were looking at a really short window of overlapping therapy of 3 days. And so some of the therapy that we identified could be patients switching treatment rather than concomitant treatment. And then diagnostic data that we identified is based on diagnosis submitted on medical claims, which could be incomplete or not accurately reflect a patient's true diagnosis. So based on this, we don't have any policy changes recommended today. And in summary, since removal of the PA, utilization for sublingual buprenorphine has increased. Most patients do have a diagnosis of opioid use disorder in their medical claims, and there hasn't really been any change in duration of therapy for MAT. There are several issues that have been brought to the attention of the OHA, and I wanted to throw those out for this group of clinicians in case you had any feedback on what might be useful to look for, if anything, for this subject. The OHA has heard about supply issues associated with sublingual buprenorphine that result in the inability to access medication-assisted therapy for opioid use disorder. Also identified issues of difficulty for patients with opioid use disorder to find an available provider to prescribe them buprenorphine. And then using an opioid use disorder diagnosis by providers to facilitate payment of sublingual buprenorphine for patients. So I don't know if there are any specific research questions or thoughts that this committee has on what might be useful to look for, or recommendations on education or anything like that that might address some of those issues, but I wanted to throw that out there in case people had ideas. And I'd be happy to take questions.
Hey, Sarah, it's Stacy. I do have some ideas. So there was a supply chain issue. I think it's done now. And it was really pretty sporadic, which I thought was weird. You know, we at our pharmacy had no problems keeping it in stock, but I know some of the other places that used a different wholesaler did have some supply chain issues. I'm wondering whether or not, so the DEA just changed the requirements for getting an X waiver and the number of patients that you can treat. I've shared it like within our provider groups, but I'm wondering whether or not that information shared more broadly might be helpful, because I think that there's still a limitation in the number of providers that do have the X waivers to treat, and then the number of patients that they can treat. And so that information has changed relatively recently. So that's what that would be my thought, is to share that information as broadly as possible, so that maybe we could at least deal with the access issue as much as possible.
Thanks, that's helpful feedback.
And I can send you those documents if it would help.
Yeah, certainly, forward them along.
This is Kat. I have mostly a curiosity, and if there was capacity to do it, I think it'd be interesting. But bupe microdosing has really transformed at least my clinical practice in terms of getting people able to start buprenorphine without requiring withdrawal periods. And I just wonder about the ability to look at that microdosing sort of more broad, like how much is it in use? You know, are we seeing that really increasing? There might be a really nice educational opportunity around that as well.
Can you describe that, Kat? And like, is that performed with the films as well?
Yeah, so this is something that we're doing a lot in the inpatient setting. So people who are currently taking opioids, for which it's either medically inappropriate or, you know, like it's medically inappropriate potentially to taper, to have them fully withdraw, you know, so rather than waiting the 24 to 72 hours to go into full withdrawal, you essentially are able to start bupe in this very microdosing amount over like I would have to look at the protocol, but it's like a 5-day period where you gradually are up titrating it. And so you can start it while somebody's on high dose of other opioids. So it's used a lot at OHSU, and I'm not sure about other institutions who are using it, but it's pretty exciting, and it's really made it so a lot more people are able to be started on bupe who otherwise would not.
And so assuming that's done with a straight, like generic Subutex, the straight bupe product, no naloxone component.
That's correct.
Okay.
And it's the patch. The patch is part of that, and then you up titrate the tablet. I could get the protocol if it would be helpful to share it.
Yeah, I'd be interested just to see it, and if we can share that with folks here at the OHA. I mean, it's certainly a topic that's being bantered about in different channels. So the more we can be abreast of what's going on and share that information, then and also look at any utilization controls that we might have. You know, we don't really have any restrictions, but it'd be good to be aware of that.
Yes, restrictions would be super annoying to try and make that happen. So it'd be good not to have restrictions on inpatient transition of use.
We certainly don't. I wouldn't imagine the CCOs do either. On the outpatient side, the fee-for-service and the CCOs have at least 30 days open access to any of the MAT therapy. But again, just so we could communicate that information to parties that would be interested, that'd be awesome.
Yeah, I mean, microdosing as a on an outpatient induction, because it's, you know, you're essentially cross tapering, you know, going down on the full agonist and while increasing the buprenorphine. It's not done a lot currently in outpatient, as far as I know. I have heard of people who kind of send patients home with you know, to do home inductions, but as far as I know, it's not done very often in outpatient, just because of the logistics of it. Yeah.
Really good information. So any other questions for Sarah? All right, I guess the recommendation in front of the committee then is no policy changes are recommended at this time. So I guess we can take a vote just to confirm that position.
Motion to make no policy changes.
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
One more reversal, of course. I just need to go back to the consent agenda. Again, we didn't present that information. It's just a standing portion of our agendas so that we can be efficient with our time and the committee's time. Nothing is being changed because of the information we're presenting there. Just teased us up to add drugs to our policy or look at things in exec session. So we need a motion to approve the consent agenda.
Motion to approve the consent agenda. This is Karen.
Thank you, Karen.
Right. This is Russ, and I'll second.
All those in favor?
Aye.
Opposed? Abstain? Thank you.
Fantastic. So the next topic we have on the agenda is our ADHD DUE, drug use evaluation, and a DERP summary. We're going to shift the two topics. I have them listed as the DUE first and then the DERP summary. But again, we're going to do the DERP summary that starts on page 72 first, just to get any new evidence out there in front of you. I'm throwing my team off with the core order of events, but we're going to turn it over to Dave Engen. And again, if you're following along in the packet posted, I did post them in the order that we're now presenting them. So direct your attention to page 72.
Okay, thank you, Roger. Yeah, so the ADHD drugs were last reviewed in August 2020. This presentation highlights relevant findings from the DERP systematic review for ADHD treatment. So next slide, please. Okay. Yeah, the DERP compared evidence between different pharmacological therapies for ADHD, notably stimulants versus stimulants, stimulants versus non-stimulants, non-stimulants versus non-stimulants, and newer drugs versus placebo. Next, as you can see in the table, the number of randomized controlled trials and study size varied quite a bit for each comparison group. And when we filter it by studies 8 weeks or longer, you see the number of eligible trials that dropped considerably. Next slide, please. So these were the 8-week trials that were assessed with grade criteria for clinically relevant ADHD outcomes. The gray row shading It indicates either there were no eligible studies for a particular outcome, or the included studies were rated as very low certainty of evidence. Therefore, those results will not be discussed in this DERP summary. Next slide, please. So for the trials of one stimulant versus another stimulant, there are no studies of 8 weeks or longer that identify differences in symptom reduction. But they found that also, SAEs were rare, with only one reported in the osmotic release oral system, methylphenidate, and one in lisdexamfetamine groups, and none in the immediate release amphetamine group. So not a lot there. If you go to the next slide. So for stimulants versus non-stimulants, there were statistically significant differences in symptom response for lisdexamfetamine compared to atomoxetine with the ADHD RS4 and the WFIRS assessments based on one trial with moderate quality evidence. 3 trials with atomoxetine versus methylphenidate IR reported slightly higher proportion of discontinuations due to adverse events in the atomoxetine group. All right, next slide, please. So for the non-stimulant versus non-stimulant comparison, DERP found just one trial that reported guanfacine ER has statistically significant difference in reduction of ADHD symptoms compared to atomoxetine, as based on low quality evidence. However, the same trial reported slightly more adverse events and discontinuations due to AEs for guanfacine ER compared to atomoxetine. You can go to the next slide, please. So lastly, the DERP reported out that the newer non-stimulant viloxazine demonstrated a statistically significant reduction in ADHD symptoms compared to placebo with 200 milligram and 400 milligram doses across multiple instruments based on low quality evidence from 2 randomized controlled trials. There were some limitations, notably many of the included randomized controlled trials were relatively short or had crossover designs with no washout period, long titrations. Often performance was measured on just one day after a short treatment period. And most trials excluded patients with comorbidities. I did want to point you to the next slide, a few clerical updates to the archived ADHD PA criteria. For our table, the first was the Midas dosing clarification. So you can see that broken out there by age and the doses. And then second was the Qelbree, the viloxazine. It expanded its indication to include kids from ages 6 years up through adulthood. So the adulthood was new. So we removed the maximum age, and I put a red box there to highlight that. I need to add the adult max dose to the table. I believe it's 600 milligram max for adults, which is more than in children. So I'll update that as well. Make a note of that. But as far as recommendations, next slide, no changes to the current OHP PDL, and then evaluate comparative drug costs in the executive session.
This is Dr. Helm. Dave, can we go back to your table with the maximum dosings?
Sure.
Okay, so once again, on the third line down where it talks about amphetamine, dextroamphetamine, extended release, the maximum daily dose is listed for adults and children. First of all, it lumps them together. There are differences between children ages 6 to, I think it's 6 to 12. they have a higher maximum daily dose to 30 milligrams, and adults have a 20 milligram maximum daily dose, which is once in the morning. And so I don't know why we continue to say that it's really okay to use more than double, triple the amount of the FDA approved dose for Adderall XR when the FDA, which we're supposed to be covering the things that are approved by FDA and not things that are not approved by FDA, says that the maximum dose for adults is 20.
Yeah, we can certainly update that. Thanks for pointing that out.
Well, it's not the first time I pointed it out.
Okay. Well, thank you. We won't overlook that this next time.
I mean, certainly in terms of treatment of adults, I mean, we would create a lot of work for OHA staff if we only covered extended release Adderall to 20 milligrams, because there's a huge number of people who take more than 20 milligrams. And so, I mean, if they were all suddenly denied a refill or, a dosage change, I mean, that would be, I mean, I don't know how many people we have
But the
on
mandate,
that.
I understand that, but the mandate for coverage of prescription products in Medicaid is that we cover the things that are FDA approved. And it is not FDA approved to use Adderall XR at a higher dose than 20 milligrams once daily for an adult. And there are other options where there's a higher amount of amphetamine that's made bioavailable. Lisdexamphetamine, which I'm no fan of, has higher delivery of amphetamine to the bloodstream than the Adderall XR formulations do.
Right. Well, and so I guess this sounds more like an administrative issue than an evidence-based one. I mean, Roger and folks, I mean, in terms of our ability to cover things beyond the FDA-approved maximum, when supported by evidence, I mean, what are our requirements there?
Well, I think you touched on it there, right? We do support the things that are FDA approved, but also if they are supported by compendia. You, Russ, had mentioned that there's probably a fair number of people that are on doses that exceed this, but Mark, you're calling out clearly that this is not approved for that greater doses. So I think we need to look at that, but then we're also hearing that look at this table for the max daily doses and parse out children from adults when there's differences, just so that's clear as well. So, but yeah, if there's evidence to support it, we can and do cover higher doses, but we'd have to look at that. So.
And in the studies that were done for the approval of Adderall XR, the evidence was that there wasn't any additional benefit, but that there were increased risks for side effects, which is why there were limitations that were placed on the 20 milligram dose for adults. So the problem is that while the compendium may say, well, there's empirical evidence from routine use that higher doses are tolerated by some people, there's also empirical evidence that says that higher doses sometimes lead to more diversion or abuse. So this is a category that's relatively sensitive to those sorts of issues, and we have to recognize and respect that the legal requirement is to cover the things that are FDA approved and not necessarily rely on compendia, which, as we know, are influenced and influenceable by people who care to influence them, basically. So there's conflicting information on the utility of these higher levels of doses for people with ADHD.
I would have to say that, I feel like there is a fairly, there's not a ton of data, period. Not as much as I would like, but there are at least, a handful of studies looking at doses greater than 20 milligrams, that, support that higher doses can be more effective, particularly in folks with more hyperactive symptoms, whereas folks with more inattentive symptoms tend to respond at lower doses. And, I mean, I don't know that this is necessarily the venue for hashing that out. I mean, it could be part of a literature review for the future. But I don't know. I mean, as someone who treats adult ADHD, I mean, folks with hyperactive symptoms predominant, it's not at all unusual for them to need more than 20 milligrams. And certainly there are other avenues, and there's therapies, and there's, you can add on clonidine and guanfacine and things like that. But I mean, there is evidence that, some folks do need higher doses. And yes, we do need to be mindful of the potential for diversion and misuse of these products. In fact, we know that they're widely misused by all sorts of folks, like law students and medical students. But we also need to make sure that we are appropriately treating folks who.
Okay, so I'm going to chime in just for one more thing to think about. So I appreciate that the FDA does issue that they don't recommend doses higher than 20 milligrams in adults. But if you look at like Up-to-Date, which is probably more commonly used as a guide, and does have some references to decent quality studies, they do comment that, doses over 40 milligrams in adults are not ideal, but doses up to 60 milligrams have been used and are safe and effective in some patients. So it sounds to me like we've got kind of I understand your point on the FDA, and yes, I would generally defer to them, but we also know that oftentimes, especially with like, if a psychiatrist or a psych NP is prescribing them, oftentimes we would see doses higher than the FDA recommendations from specialists. And so I think that's one other thing in this discussion to consider, is that there may be times where we do exceed that dose, and not saying we need to do it all the time, but I think that it probably is reasonable in some cases. So.
I just want to clarify a couple of things that you said there. One is that the FDA doesn't say is not recommended; they say is not approved above. The maximum dose is 20 milligrams because the adverse effects to benefit ratio was unfavorable. So it's not that they're saying it's not recommended; they're saying it's not approved. And the language with Medicaid coverage is relating to approval. And second, Up-to-Date is not an evidence-based product. I actually had a title on Up-to-Date for a number of years on an area that I wasn't really a subject matter expert on, but no one else had written it, and I was asked to by the editors. But Up-to-Date is not evidence-based and not necessarily evidence-informed. It's mostly individual, academic thought leader opinion. So it is not a guideline, and it's not a compendia that we can actually rely on. If you want to talk about facts and comparisons and some of the other things, those are actually influenceable by individuals. I've done that myself in a prior role. When I noticed that there was something that was in facts and comparisons, it was incorrect, and sent them a letter and they corrected it.
No, and I'm not disagreeing, Mark. I'm just saying that if you go to Up-to-Date and actually pull the studies from where their recommendations from their sources, they're not terrible. So yes, I totally agree with you that they are not necessarily all evidence-based, but you can usually find the evidence to support the recommendations in the reference section.
And that goes back to a question, for the DERM program or DERP program, what is the quality of the studies that they're basing that on? And were there adequate and appropriate controls? There's a lot of issues with, you can find a study that supports whatever you want it to support.
All right, so here's the proposal. We're planning to bring this topic back simply to look at some of the supplemental rebate offers in October. Great conversation going on right now. I think we'll look at this, look at those doses. Mark's contention that it says it's not approved above this with the FDA labeling, but our mandate that we also approve things that are supported by compendia, and Russ's contention that, you know, there's individual diversity with people's metabolic rates and what's going on. So we're going to look at the data. We'll bring it back. We'll also try to quantify what our utilization is, because if we're talking about having a hard stop, that's going to have dramatic effects on people, and we need to talk about that and say, you know, see what a plan would be at that point. So to be continued, we'll bring that back.
Roger,
but back to what
one more.
Yeah,
on
please.
this. There is a difference between the maximum approved dose for the standard release formulations versus the extended release formulations, and that difference, I think, is one that relates to the timing and duration of the medication and when it's delivered. While 20 milligrams is a maximum for the extended release formulation, which has that peak concentration at 7 hours roughly post the dose, the standard release formulations, which are fairly long acting at baseline, their maximum dose for adults is 30 milligrams. So there's differences between the standard release formulation dose and the sort of fixed extended release dose as well. So for those
Excellent
people
point taken.
who need more, there's the opportunity for actually shaping the dose in the way that it would be most advantageous for the individual, rather than sort of relying on the fixed extended release formulation, which for Adderall XR is fairly simple-minded.
Well, but I mean, when we start talking about the risk of diversion, though, I mean, we tend to try to avoid the immediate release amphetamines, specifically, and not that extended release Adderall is that difficult to misuse, but research has supported that 2/3 of misuse typically occurs with the immediate release doses.
Yeah, I think if you look at the populations that you talked about earlier, you'd find that Adderall XR is just as divertible as the standard release formulations. And I think that's more of a question for law enforcement and things like that. We're primarily concerned with what's actually the FDA approval, in my opinion. And I may be alone in that opinion, but that would seem to be the thing that should be covered. And I would encourage looking at like what numbers of patients who are receiving their medications through OHP have more than once daily dosing of not just the extended release amphetamine, but also all extended release formulations. Because it seems like if you're taking more than one dose per day, then you're already, the question is why not use a standard release formulation if you're dosing it multiple times per day.
Great points, and you've got a lot. I know my team is taking notes right now, so lots for us to chew on and bring back in regards to the dosing parameters and the impact of any decisions we might be considering. So thank you for that. I'll draw attention if we have a draft material, so we certainly have your input. And again, we'll tentatively be planning to bring this back in October. So back to your recommendations, Dave, from your section of this presentation. If I'm right, it's just that there are no PDL changes recommended based on this recently published evidence?
That's correct.
Awesome. And we will be reviewing this in executive session. We do have some public comment from one of the industry representatives. We're going to hold on to that until we finish our DUE. So now I draw your attention to page 95 in the packet. And we have a resident with us, Gary Karagowski. I never tried to pronounce your name first. I just stumbled all over myself here, Gary. Sorry about that.
No worries. So
the floor is yours on page 95 in the packet.
all right. Well, afternoon, everyone. My name is Gary Karagowski. I am a second-year pharmacy resident here at OHSU Richmond Clinic, and I'll also be reviewing my drug use evaluation on the focus of ADHD drugs. Next slide, please. So the purpose of this evaluation is to evaluate the use of combination ADHD medication therapy in children, adolescents, and adults in the Oregon Medicaid population. Next slide, please. And just for some quick background on current treatment recommendations for ADHD, there is good established evidence and support from some guidelines of the use of stimulants as first-line agents and non-stimulants as second-line therapies. However, the use of combination therapies with non-stimulants are typically limited to the use of guanfacine extended release and clonidine extended release as adjunctive therapies to stimulant therapies. And the evidence for those really support the use within children's and adolescents only. Next slide, please. So currently, Oregon Health Plan does have the ADHD safety edit as current policy, which has a goal to cover ADHD medications only for diagnoses funded by OHP and for medications consistent with current best practices. This safety edit further has a goal to promote care by mental health specialists for patients requiring therapy outside of best practice guidelines, as well as promoting preferred drugs within the class. Typically, this edit also requires the need for a prior authorization in a setting where a non-preferred drug is on an enforceable preferred drug list, where a regimen prescribed outside the standard dose and age range are present, as well as other incidents of non-standard polypharmacy. Next slide, please. And here is just the current FDA-approved and OHP-funded indications for the use of these agents for ADHD. So stimulants, we have methylphenidate and amphetamines and their derivatives, both ADHD and narcolepsy, approved for ages 6 years and older, for the caveat of amphetamine derivatives being for those of ages 3 years and older. And the use of non-stimulants of amoxicillin, clonidine, extended release, guanfacine, extended release, and naloxone for those, I guess for clonidine and guanfacine, children ages 6 to 17 years only, and naloxone ages 6 years and up, and are not approved in those with the, for the indication of narcolepsy. Next slide, please. So the main research questions for this evaluation were to look at what percentage of patients were prescribed combination therapy for treatment of ADHD. What are the characteristics of these patients who are utilizing these combination medication therapies for treatment of ADHD? What is the incidence of emergency department visits and or hospitalizations due to drug overdose or adverse events from patients utilizing these combination medication therapies for ADHD? And what proportion of patients utilizing combination medication therapy are prescribed ADHD treatment by a specialist? Further, this project also kind of continued some of the research questions from the previous ADHD DUE that was completed in 2019, and also looked at how prescribing patterns and utilization of ADHD medications in adults enrolled in OHP changed over the previous 5 years. So for methods, this was a retrospective descriptive cohort study. The policy period of interest was patients of all ages with a pharmacy claim for an ADHD drug with either a stimulant or a non-stimulant from January 1st to December 31st of 2021. We excluded additional insurance coverage, those with additional insurance coverage through Medicare, and had less than 75% fee-for-service or care coordination organization eligibility during the year 2021. And for the purpose of this evaluation, combination therapy was defined as the incidence of overlapping claims for 2 different medications within 60 days, and had no more than a 14-day gap in overlapping therapy for the next expected fill dates. Next slide, please. When looking at the incidence of emergency department hospitalization visits, this looked at the presence of claims for ED visits or hospitalizations that corresponded with a diagnosis code relating to the reason for visit, and had to occur after the date of first medication claim for the year 2021. And when looking at combination therapy prescribed via a specialist, this was done by prescriber taxonomy and included that of a psychiatrist, developmental pediatrician, psychologist, psychiatric nurse practitioner, sleep specialist, or neurologist to be considered as a specialist. Next slide, please. That second part from that continuation of the 2019 DUE, this portion was limited to adults only and those who had a fee-for-service ADHD pharmacy claim from 2016 to 2021, and additionally included utilization of those with a diagnosis of opioid or alcohol dependence within that previous year. Next slide. And lastly, you also took a brief look at the frequency of approved prior authorizations. These had to be requested and denied prior authorizations in the year 2021 were within the fee-for-service population only, and also looked at the follow-up events after a denied claim for up to 90 days. So next slide, please. So looking at the results, so most patients had claims for a stimulant only, about 75% of the total population, with 62.2% of stimulant monotherapy in those ages 18 or older. The most common combination therapies consisted of stimulant plus a non-stimulant, and 62.2% of this combination was prescribed to patients 12 years of age or younger with limited use seen in adults. There was also limited use of stimulants plus another stimulant, seen in 1.2% of the total population, and non-stimulant plus a non-stimulant, which comprises less than 1% of the total population. Next slide, please. So patient sex assigned at birth was similar for the total claim population, with males predominating at 50.6%. However, males were more frequently prescribed combination therapy, particularly in the stimulant plus non-stimulant and non-stimulant plus non-stimulant cohorts. For looking at some other demographics, documentation of ADHD diagnosis was 71.6% and was overall consistent with all cohorts except for those utilizing a non-stimulant only, where it was 60.4%. And the dominant ethnicity reported in this population was those who were white, with 33.4%, but it should be noted that 49.7% of the total population was listed as unknown. Next slide, please. When looking at additional indications that coexist or mimic ADHD, the presence of a comorbid mental health disorder was observed in 45.3% of patients and were most commonly seen category that coexist or mimic ADHD within this population. Next slide, please. We're looking at the frequency of a specialist prescriber for an index ADHD claim for the year 2021. 31.2% was present within the total population, though frequency was higher with those with the non-stimulant only, stimulant plus non-stimulant, stimulant plus stimulant, and non-stimulant plus non-stimulant cohorts than that was seen in the stimulant only population, which is as low as 26.9%. The presence of an index claim for the additional points of interest that exceeded the maximum recommended dose of agents or claims for agents outside the recommended age was low and overall consistent between cohorts. Next slide, please.
Hey, can you when you were talking about conditions that mimic ADHD, mental health conditions, do you happen to know what was included in that?
Yeah, that was a presence of things such as depression and other things. I believe could refer you to the packet. They should all be listed in the appendix on what that comprised of in totality.
I didn't make it as far as the appendix. I always check the appendix. Okay, thanks.
All right. So I believe next, that's slide, okay. So looking at the negative safety outcomes in 2021, there were a total of 8,778 emergency department visits and 952 hospitalizations. There did not appear to be a higher rate of either in the combination groups compared to those within the monotherapy cohorts. And the most common associated diagnosis for either ED visit or hospitalization was suicidal ideation, which was reported in a low percentage across all cohorts. And a total of 7.7% of all individuals had a cardiovascular comorbidity and 5.2% had a substance use disorder diagnosis. And these were lower in the combination groups. Next slide, please. So this graph is a continuation from 2019 DOE and illustrates the trends of the fee-for-service ADHD pharmacy claims for adults from 2016 to up to late 2021, early 2022, and adjusted to per member per month by 1,000. And from 2016 to February 2022, the total utilization adults have increased from 8.75 per member per month to 18.3 per member per month. Next slide, please.
It doubled.
Yep. This graph further illustrates adult patients with a fee-for-service ADHD claim for adults from 2016 to early 2022 who had a diagnosis of substance use disorder present in the year prior to the ADHD drug index claim, which was previously reviewed in 2019. And there was a gradual increasing trend as noted from 2016 to 2020. So the increasing trend begins to plateau in 2020 and ranges between 3.68 per member per month to 2.68 per member per month from January 2020 to December of 2021. Next slide, please. These results look back at the frequency of ADHD drug index claims for the fee-for-service only population from the calendar year 2021. There's a total of 8,083 patients with denied fee-for-service claims for that year. And of the denied claims, 79% had a claim paid within 30 days of the denial. The most common reasons for the initial claim denial were those eventually had a claim paid within the next 90 days, included brand formulation of the medication was required, the drug quantity per day limit was exceeded, a non-preferred medication was being requested, or the claim did not meet age limit criteria set by the ADHD safety edit. And of the 15% of patients who with denied claims and no paid claims in that 90 days, a prior authorization was not requested for 83% of those total claims. Further, the next graph displays a fee-for-service ADHD prior authorization request for the year 2021 calendar year. Of the total PA requests submitted, 93% were approved. While this is a high percentage of PAs, it should be noted that all denied claims resulted in a prior authorization request. And of the 7% of PAs that were denied, 97 cited that the claim did not meet the criteria for approval established by the current ADHD safety edits. So overall, there appears to be a high number of denied claims that were eventually approved. And the reason for the 1,226 denied claims that never had a paid claim is currently unknown. And additionally, the reason for the high approval rate of PAs is also unknown. Next slide, please. So in conclusion, out of 39,351 patients with claims for an ADHD medications in the 2021 calendar year, 7.2% used multiple agents concurrently. Of those patients using a second non-stimulant agent, 68% had a recent diagnosis of either developmental or mental health disorders, and these patients were more likely to be male and young. The incidence of emergency department visits or hospitalizations for those utilizing combination therapy for ADHD was 24.6% and did not significantly differ from those utilizing a single agent for ADHD treatment. Approximately 49% of individuals using a combination of agents for the treatment of ADHD had therapies prescribed by a specialist. And lastly, utilization of ADHD medication in adults had increased by 95% per member per month from 2016 to 2021. Next slide, please. So for recommendations, no revisions to the current ADHD safety edits are recommended at this time. We recommend to continue to monitor the use of combination therapies for the treatment of ADHD and evaluate for any changes in trends over time. And lastly, to consider additional education about the need for appropriate treatment of mental health disorders in those with ADHD. Next slide. And then with that, I will turn the mic back.
Great job, Gary. Questions on the DUE?
That's a rather extraordinary increase in the last 6 years in the treatment of ADHD with stimulants for adults. Just would be curious of people's thoughts about that.
I think it's advertising.
Yeah, I agree. I mean, TikTok and, Vyvanse and it's all over the place. I mean, there are scripts online for here's the things to say in order to get a diagnosis and be approved. So, I mean, although I'll also say, there's also increasing awareness. And so we are seeing some folks, particularly in the last year, who, functioned very well until they had to work from home. And so there are some folks who had been kind of muddling through and then, as a result of the pandemic, found their symptoms became untenable. But yeah, I mean, I think a lot of it just has to do with the fact that it's out there and talked about and advertised in there's lots of ways. So I was looking at Appendix 3 and I noticed PTSD isn't in your list. I mean, not that it matters at this point, but I think that is a diagnosis that's often confused or can exacerbate ADHD or be misdiagnosed as ADHD or et cetera. So
interesting. So maybe it wasn't found in the literature, but that's your experience.
Yeah, I mean, it is. I mean, if you consider that until 2013, it was listed as an anxiety disorder. I mean, it's a diagnosis that often includes, anxiety, which, is, and involves executive dysfunction, and so I mean, it's a diagnosis that frequently involves, dysregulation of executive function. So, yeah,
you bet. No, it's good information.
I would say also, and you might or might not see the diagnosis that snoring actually is one of those things that contributes to inattention symptoms. So I completely agree with Russ. Is like PTSD is like one of the huge drivers, and sometimes it's difficult when you have a person who you're treating who has a significant trauma history, and they also have attention and focus issues. It's really hard to tell, is it the trauma and their heightened alertness in it's not alertness, heightened vigilance for threat that's preventing them from paying attention, or is it just like some sort of basic inability to focus and attend to things that they may or may not outgrow. So that PTSD is really important. So are anxiety disorders, and then so is just basically your sleep. If you get poor sleep, you can't focus and pay attention.
Yeah, absolutely. I mean, I think probably the medical diagnosis that I talk about more than anything is probably sleep apnea and the correlation that it has with cognitive function and mood and things like that. So yeah, absolutely.
Good conversation, and we'll continue to monitor this. We do have some public comment. Any other questions for Gary before we entertain the comment?
I have one thought.
Yeah,
so
please,
Gary,
Stacey.
So yeah, I mean, I agree with all those comments. It's a crazy number or a crazy amount of an increase. And I agree that I like to think maybe it's more awareness rather than strictly advertising, but I know that's a little, maybe that's a little optimistic, but I'm still going to go with it. Gary, on those, I actually was interested in the people who got the claims denied, but then no PA or we don't know what happened to their prescriptions after the 90 days. Would it be possible to go back and look at PDMP and see if those were actually filled for cash versus claims? I just think it would be interesting to see.
We do too.
Okay, you do too. All right. Perfect.
Yeah, but we can't see the PDMP. Legislatively, we are prohibited from looking at that.
Yes.
So only providers could go look at their claims, but so there's a disconnect there, Stacey, but you're absolutely right. It would be so interesting and we could learn so much from PDMP data, but nope.
That's right. I forgot about that. I'm like, oh, just look in PDMP,
Yeah.
but right, you can't do that. Okay. Just a thought.
Oh, that's a great thought. I would love to. Maybe, yeah. Yep. All right, with that, we do have Patrick Harvey with Supernus Pharmaceuticals. I made you a co-host to enable you to unmute yourself. Are you able to do so, Patrick?
I did. Can you hear me?
Can hear you loud and clear.
Great.
You have up to 3 minutes of public comment to address the committee, so the floor is yours.
All right, thank you. Good afternoon. My name is Patrick Harvey with Supernus Pharmaceutical Field Medical Affairs. I want to thank you for the opportunity to make a few comments regarding Qelbree. Please refer to our complete prescribing information for full product details, including our black box warning on suicidal thoughts and behaviors. Since your last review, it's indicated in the review that we have concluded an adult trial, and based on that trial, FDA has granted Qelbree an adult indication. In the adult trial, Qelbree showed significant improvement in adult ADHD investigator symptom rating scale early in treatment at week 2. Patients also showed significant improvements on the hyperactivity, impulsivity, and inattentive subscale, indicating symptom improvement over placebo. Moreover, patients showed sustained symptom improvement over the course of a 1-year open label extension study. And on a global measure of functional improvement, patients on Qelbree showed significant improvement over placebo on the clinical global severity scale as early as week 2 as well. ADHD non-scheduled medicines such as atomoxetine may take a median time to improvement of 4 weeks and after treatment initiation, and at least 12 weeks to full response and 14.3 weeks to remission. Up to 90% of patients diagnosed with ADHD in childhood and adolescence continue to experience difficulties in adulthood, and we know that over 80% of adults with ADHD are currently undiagnosed and are untreated. There are currently no treatment guidelines for adults in the United States. Therefore, therapy is driven by habit and children's guidelines. In 2015, it was estimated that an average of 5 million adults living in the United States misused prescription stimulants in the previous year, and 52% of youths have admitted to engaging in 1 to 3 forms of diversion of stimulants. Half of young adults with ADHD report lifetime substance use disorders. Qelbree is non-scheduled and has shown no abuse potential. High blood pressure is the most common chronic condition in adult patients, and adding medications that further exacerbates high blood pressure may not be an appropriate option. Currently, the only other non-stimulant option approved for the treatment of adult ADHD carries warning signs for serious cardiovascular events and severe liver injury. Qelbree's impact on cardiovascular parameters, including heart rate and blood pressure, were mild, and no patients in adult trials discontinued due to cardiovascular adverse events. Even at super therapeutic doses, had no impact on QTc prolongation, and no ECG changes were observed. It's for these reasons we ask Qelbree be considered for PDL, and I'd be happy to answer any questions you might have at this time. Thank you for your attention.
You think you practiced that to make it 3 minutes? Great job.
A few times.
You bet. Any questions for Patrick? All right. Thank you for your time. So we'll go back to the recommendations. I don't think we're making any ones major. Again, no revisions based on the safety edits are recommended. Continue to monitor. And we'll also consider additional education about the need for appropriate treatment for mental health disorders. Anything you want to add to that committee, or motion to approve?
Motion to approve.
Is there a second?
Second.
No second? Okay.
Second. Yeah, sorry about that.
All those in favor?
Aye.
Aye.
Opposed?
Opposed, primarily because I think that the dosing is incorrect on the combination or the extended release formulation.
Abstain? All right, thank you.
And we will be reviewing an executive session. So just wanted to call out, Sarah's sending a chat to everybody, but for those of you who've joined the meeting as we're in progress, for the sake of our minutes and collecting accurate information, if you've joined, you have the ability to hover over your name and add your affiliation, be it manufacturer if you're with industry, or if you're with a CCO. So we'd appreciate you doing that. Let's see, we're at 2:56. Let's stay on course. Do one more subject and then we'll take a break. Does that work for the committee, or do you need a break now?
We can wait a little bit.
All right.
Yeah, I'm good.
Let's go through one. Sorry, Russ.
Oh, I was agreeing with Robin. I'm good.
Awesome. Awesome. Appreciate it. It's kind of a little more flexibility when we're kind of doing this remotely, right? We can't see. So, all right. Draw your attention, if you're following along on the packet, to page 118. And we're going to do the diuretic literature scan and turn it over to Megan.
Thank you, Roger. Okay, so today I'm going to be presenting on the oral diuretics and a new drug evaluation. Next slide. So the purpose of this class update was just to look for new comparative evidence for the effectiveness and safety of the oral diuretics for prevention of mortality and cardiovascular disease, and to also look at the data for efficacy and safety of the new medication Phenerenone and determine its appropriate place in therapy. And the last time this class was reviewed was in June of 2020. So there were 4 systematic reviews that were identified, including 2 Cochrane collaboration reviews that were evaluating aldosterone antagonists in patients with chronic kidney disease. And one was specifically looking in those with chronic kidney disease requiring hemodialysis. The first one evaluated the effects of aldosterone antagonists in combination with ACE inhibitors or ARBs in adults with CKD on kidney failure, major cardiovascular events, deaths, and adverse events. Risk of bias was high or unclear in many studies, and none were powered to detect differences in clinical outcomes. Overall, there was low quality evidence evaluating these agents on clinical outcomes in CKD, and low quality evidence of an uncertain effect on kidney failure. There was moderate quality evidence of an increased risk of hyperkalemia with a number needed to harm of 41. And there remains insufficient evidence really evaluating aldosterone antagonists on clinical outcomes in patients with CKD or comparing these agents to other active treatments in CKD. The second systematic review evaluated these agents in comparison to placebo or standard of care in those with CKD requiring hemodialysis. And there was moderate quality evidence that aldosterone antagonists may reduce all-cause death, CV death, and CV events in those with CKD requiring hemodialysis. Next slide. And then there was another Cochrane systematic review that was done to determine if medications, including aldosterone antagonists, are beneficial in those patients with heart failure with preserved ejection fraction or HFpEF. A total of 13 studies were included, and 10 of those were evaluating spironolactone. And there was moderate quality evidence of no significant effect on cardiovascular mortality or all-cause mortality compared to placebo or standard of care. But there was a significant reduction in heart failure hospitalizations with an absolute risk reduction of 3% and number needed to treat of 41. And then high quality of evidence of an increased risk of hyperkalemia with a absolute risk increase of 8% and number needed to harm of 13. Next slide. So the new medication that was approved in 2021 is Phenerenone or Kerendia. It is a non-steroidal mineralocorticoid receptor antagonist that is highly selective for the mineralocorticoid receptor. It was FDA approved to reduce the risk of eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure in adults with chronic kidney disease associated with type 2 diabetes. Next slide. It was FDA approved based on one placebo-controlled, double-blind, randomized controlled trial in adults with type 2 diabetes and CKD on maximum dose of either an ACE inhibitor or an ARB. CKD was defined as moderately elevated albuminuria, eGFR of 25 to 60, and a history of diabetic retinopathy, or severely elevated albuminuria with the eGFR less than 75. And the primary outcome was a composite of kidney failure, sustained decrease of at least 40% in eGFR, or death from renal causes. This trial did consist of a 4 to 16 week run-in period to allow for optimization of standard of care with ACE and ARB, and then an additional 2-week screening period. Most patients had significant albuminuria with urinary albumin to creatinine ratio greater than 300, and the mean eGFR was 44.3. And after a median follow-up of 2.6 years, there was a reduction in the risk of the primary composite outcome with Phenerenone compared to placebo, 17.8% versus 21.1%, with an absolute risk reduction of 3.4% and a number needed to treat of 29. And this was largely driven by a reduction in the sustained decrease in eGFR and kidney failure. There were very few renal deaths that occurred in the trial, less than 0.1%. And then this difference was less than the absolute benefit that has been reported in clinical trials of SGLT2 inhibitors in a similar population. And there is insufficient evidence evaluating use of Phenerenone in addition to an SGLT2 inhibitor. And then there was a secondary outcome, a cardiovascular composite outcome. There was a modest reduction in composite of CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. And then there was one more similarly designed trial that was published after FDA approval that can be found in the packet, but the primary outcome in the second trial was a composite cardiovascular outcome, and it also showed a modest benefit in patients with chronic kidney disease and type 2 diabetes with a reduction of similar, about 1.8% in the cardiovascular outcome. In terms of safety, more patients taking Phenerenone discontinued treatment due to adverse events than those in placebo, 7.3 versus 5.9. The most common reason for discontinuation was hyperkalemia. Phenerenone is contraindicated with concomitant strong CYP3A4 inhibitors and has a warning for hyperkalemia. You can see here there was a higher rate of hyperkalemia-related adverse effects, a higher rate of discontinuation due to hyperkalemia, and higher rate of hospitalizations due to hyperkalemia. Next slide. The overall trial limitations is there was unclear attrition bias with high overall rates of attrition of close to 30%, but they were similar between the groups. As I mentioned, this trial had extensive inclusion and exclusion criteria and a run-in and screen-in period that decreases the generalizability and external validity of the over 13,000 patients that were initially enrolled. Only 5,734 were randomized. And so over half of patients were excluded during this run-in and screen-in period, mostly due to not meeting eligibility criteria. Almost all patients were on an ACE and ARB at baseline. However, only 22% on ACE and 55% of ARB were on maximum recommended doses, and very few patients were on an SGLT2 inhibitor. And then lastly, the study was funded by the manufacturer, who had significant involvement in the study design process, and many of the study authors had financial conflicts of interest disclosed. So our recommendations are no changes to the PDL based on clinical evidence, and to evaluate comparative costs in executive session, and then to maintain Phenerenone as non-preferred on the PDL and include prior authorization to limit use to patients with chronic kidney disease and type 2 diabetes on background therapy with an ACE inhibitor or an ARB. So the PA criteria can be found on page 139 and is summarized here in this slide. But again, it is asking that the patient does have type 2 diabetes, a diagnosis of chronic kidney disease, but not requiring hemodialysis or creatinine clearance less than 25, and that they are on, again, maximally tolerated ACE or ARB and have serum potassium less than 5. Next slide. And with that, I will take any questions or public comment.
Yeah, we don't have anybody signed up for public comment, Megan. Any questions for Megan? Okay. Hearing none, again, the recommendations in front of the committee are there on the screen. No changes based on the information recommended this time. Evaluate the comparative costs and maintain Phenerenone as non-preferred on the PDL, and include in the PA criteria to limit the use to patients with CKD and type 2 diabetes on background therapy. Do we hear a recommendation?
Do we have a motion?
I move to approve.
Second.
I'll second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thanks, everybody.
Fantastic. We're just a couple minutes ahead of schedule, so I think we're going to take a 15-minute break right now. I'll put the timer up on the screen. So we'll see you back here in 15 minutes. Okay, we're back in session. Hope everybody had an adequate break. Deanna, I see you're prepared to rock and roll. You got your big subject. Looks like we still have the full quorum of the committee. If you're following along again in the packet, draw your attention to, I believe it's page 141 for the start. And Deanna, we'll turn it over to you.
Thanks, Roger. So this is a bit of a long topic because we'll be reviewing 3 new drugs. In the interest of time, I'm just going to focus primarily on the new drugs, briefly review the DERP summary, and only focus on high quality evidence. As Roger said, the review begins on page 141. The drugs that we will be discussing are outlined in table 2 on page 148 of the packet. And the summary of the DERP review will follow the outline of the table. So we'll be discussing off-label drugs, FDA drugs that have already been approved, and then newly approved drugs. The PDL status for all of these medications is listed in Appendix 1 on page 166. And I'll just draw to your attention to the fact that we are talking about 3 different PDL classes because the drugs that have FDA approved indications for atopic dermatitis overlap based on their mechanism of activity. So in the interest of brevity, the drugs that are presented in Appendix 1 are just the drugs that have FDA approval. As a reminder, since mild to moderate atopic dermatitis is generally not funded by HERC, all of these medications are subject to PA review to ensure appropriate use for a funded condition. We could go to the next slide, please. So first thing I wanted to point out is earlier this year, the Health Evidence Review Commissioner, HERC, updated Guideline Note 21, which is focused on diagnosis of inflammatory skin conditions. So HERC included vitiligo as an inflammatory skin condition that could be covered by OHP. And then for the assessment of the severity of atopic dermatitis, HERC also added having symptoms on the face as a criteria for serious atopic dermatitis. Next slide, please. Several guidelines have been published regarding the pharmacologic management of atopic dermatitis, but they're a bit old. 2004, NICE put some guidance together. The American College of Dermatology put some guidance together in 2014. And then CADIF put some guidance together for dupilumab once it got the approval for atopic dermatitis. So right now, the guidance states that first-line pharmacologic agents are topical corticosteroids, followed by the topical calcineurin inhibitors, either tacrolimus or pimecrolimus. And the guidelines still recommend using systemic immunomodulators such as cyclosporine, azathioprine, methotrexate, mycophenolate, or oral corticosteroids as third line. And then last line agents are the targeted immune modulators. I anticipate as we get new guidance developed that the role of the targeted immune modulators may become more prominent than what it is right now. But since the guidance is old, that's what our PA criteria is based upon. Next slide, please. So just real briefly, all of the immunosuppressants that are used in atopic dermatitis are prescribed off-label, although as we've discussed previously in this meeting, if it's compendial, in other words, if it's listed in Micromedics as an off-label indication, we can cover it. So the studies for the immunosuppressants are really old. They're over 10 years old. A lot of them were small, they're in small populations, and they had high attrition rates. But we did have moderate quality evidence that showed no difference between azathioprine and methotrexate. When they looked at the 3 scales that are used to evaluate atopic dermatitis, if you're interested in more information about the scales, that is listed on table 1. Page 146 of the packet. We've talked about the EASY score and the investigator's global assessment before in the context of atopic dermatitis. Excuse me, and all of these scores have been validated and are generally used in clinical trials. We had moderate quality evidence about the adverse effects with azathioprine. And then there was only one trial that looked at topical tacrolimus compared to cyclosporine, and it showed that the topical agent was superior to the oral agent. Finally, DERP included omalizumab. They were looking at that for atopic dermatitis. It has no compendial basis to use in atopic dermatitis. And the one study that they used showed that it was more effective than placebo, but the improvement did not achieve the minimally clinically important difference that we like to see on the SCORAD scale. Next slide, please. In terms of the drugs that are already approved for atopic dermatitis for this 22 DERP update, no new studies were identified for crisaborole or tacrolimus. Dupilumab was used as an active comparator in 2 trials, and I'll get into that in a little bit more detail when we talk about the newer drugs. And then there was 1 study in infants looking at pimecrolimus versus topical corticosteroids, and it showed that both of them were effective and they had similar rates of adverse events. Next slide, please. All right, now we will move into the new drugs. The DERP compiled all this evidence, but I did try to put evidence tables together for the studies for each one of these drugs. So for this drug, Aprocytinib, the table 3 on page 151 summarizes the studies that the FDA looked at to bring this, to give approval for this drug. So Aprocytinib is a oral JAK1 selective inhibitor, and it's FDA approved for the treatment of adults that have refractory moderate to severe atopic dermatitis if their disease is not adequately controlled with other systemic drug products, including biologics, or if the use of those drugs is inadvisable. In the phase 3 randomized controlled trials, Aprocytinib was superior to placebo in achieving both an IgA response of 0 or 1, which is clear or almost clear skin, and achieving EASI 75, so 75% improvement in the symptoms by week 12 or 16, depending on which trial we were looking at. Next slide, please. Oh, this was the drug that dupilumab was used as an active comparator, but the study was not adequately powered to detect differences between dupilumab and Aprocytinib. This drug does have a lot of safety concerns, and the safety concerns that are outlined on this slide, we will revisit again when we talk about the PA criteria. The adverse events are summarized on table 4 in page 153 of the packet. In all 3 trials, thrombocytopenia was a noticeable adverse effect that was noticed in the first few weeks of treatment. It was a transient drop in platelets. It appeared to be dose related, and no participants discontinued clinical trials due to this adverse effect. However, because of this effect on the platelets, antiplatelet therapies, except for aspirin, 81 milligrams a day or less, are contraindicated during the first 3 months of treatment. Lab monitoring is recommended because there are potential changes not only in platelets, but possibly in lymphocytes and lipids. And if the patient has severe renal or hepatic impairment, the dose needs to be adjusted. And this drug also has, because it's metabolized by the liver, it has some significant drug interactions that may require dosing adjustments. And finally, like all the JAK inhibitors, this drug has an FDA box warning regarding the adverse effects that are outlined here on this slide. Next slide, please. The next drug we're going to talk about is a cream, which is a JAK1 and JAK2 inhibitor, Ruxo Light Nib, which is FDA approved for mild to moderate atopic dermatitis in non-immunocompromised patients that are 12 years of age and older, if their disease is not adequately controlled with topical prescription therapies, or if those therapies are not advisable. So table 5 on page 154 summarizes the study characteristics and results for this drug. Compared to placebo, ruxolitinib was effective in improving the EASI and achievement of IgA 0 to 1 scores in patients with mild to moderate atopic dermatitis. Next slide, please. The adverse effects are presented on table 6, which is on page 156 of the packet. No significant differences were noted between placebo and ruxolitinib in the clinical trials. Application site pain was the most frequently reported adverse effect that was noticed in both groups. And again, because this is a JAK inhibitor, it does have an FDA black box warning regarding these possible adverse effects. Next slide, please. So our final new drug is a IL-13 antagonist, which is formulated for subcutaneous injection, tralokinumab. It's FDA approved for the treatment of moderate to severe atopic dermatitis in adults if their disease is not adequately controlled with topical prescription therapies, or if those therapies are not advisable. The table 7 in the packet on page 157 summarizes the study results. And in the clinical trials, there were 2 phase 3 randomized controlled trials that just looked at tralokinumab monotherapy, and moderate quality evidence showed that tralokinumab was superior to placebo in achieving EASI-75. The IGA score was determined to be low quality evidence due to inconsistency and indirectness. There was another trial that patients were able to use tralokinumab in combination with topical mometasone. And in that trial, both scores, the IGA score and the EASI score, had significant improvement at 16 weeks of treatment. Next slide, please. Page 158, table 8, has the summary of the adverse effects that were observed in clinical trials. Not surprisingly, this drug can cause upper respiratory tract infections and conjunctivitis. If you remember, dupilumab also has similar side effects. And it's recommended to avoid the use of live vaccines during treatment with tralokinumab because of the risk of immunosuppression. This drug does not have a black box warning, but hypersensitivity is listed in the warnings and precautions. So there's a possibility of delayed anaphylaxis or angioedema after the drug has been taken, which you see with all of the interleukin inhibitors. Next slide, please. And then our final drug is Eupatacytinib, which is an oral JAK1 inhibitor that was originally approved for rheumatoid arthritis, and it received expanded FDA approval for treatment of moderate to severe atopic dermatitis in January 2022. The study data is on page 159 in table 9, and that summarizes the phase 2 and phase 3 trials. In the trials, high quality evidence showed that Eupatacytinib was superior to dupilumab in achieving EASI-75 with the number needed to treat of 10. The adverse effects were similar when compared to placebo, except for higher rates of acne that were observed with Eupatacytinib. When they compared Eupatacytinib with dupilumab, they also had similar rates of adverse effects, except there were higher rates of acne, upper respiratory tract infections, and increased CPK observed with Eupatacytinib compared to dupilumab. Next slide, please. I wanted to mention we have a late-breaking new indication for dupilumab. It was approved last month for treatment of eosinophilic esophagitis in adults. We haven't had time to review the evidence for it or revise our PA criteria, so our plan is to bring this back to the August meeting for P&T committee review. Next slide. This is a very busy slide, and I apologize, but as I pointed out at the beginning of this presentation, the PA criteria, there's 3 separate PA criteria that are impacted by adding these 3 drugs to the PDL and then looking at the expanded indication for Eupatacytinib. So the first recommendation is to update all of our clinical PA criteria for any of the drugs that are used to manage atopic dermatitis to reflect the updated HERT guidance that now includes the facial involvement in the severity assessment of atopic dermatitis, as well as severe vitiligo as a funded condition. And then we're going to revise the title for topical therapies for AD and psoriasis. We're going to call that topical agents for inflammatory skin conditions to reflect the fact that more conditions might be covered under the PA. And then we will add topical Ruxo Light Nib to that clinical PA criteria and designate it as non-preferred on the PDL. The next PA criteria we'll look at are the ones that were previously called monoclonal antibodies for severe asthma. What we're going to do is expand that to be called targeted immune modulators for severe asthma and atopic dermatitis. And we'll add the oral Aprocytinib and the injectable Trello to that PA criteria and designate both of those agents as non-preferred on the PDL. And then our last PA criteria that we'll take a look at will be the targeted immune modulators for autoimmune conditions. We're not changing the name of that one, but we will be adding Eupatacytinib to that criteria with the atopic dermatitis assessment. And then finally, we will look at the cost for all of these drugs in executive session. So I want to just go through the changes one by one for each set of the criteria. Thank you, Sarah. So the first one is the topical agents for inflammatory skin disease. And as you can see, what we're doing here, all the changes are highlighted in red. They're also highlighted in red in the packet. The PA criteria begin on page 172 of the packet. So the other thing is we're going to add a statement that the PA only applies to the topical agents, and if there's an oral or a injectable agent, there's separate criteria. And then we'll add Ruxo Light Nib to table 1, which describes the FDA approved ages for topical AD drugs. Next slide, please. Instead of saying mild to moderate atopic dermatitis or psoriasis in question 2, we revised that question to just say inflammatory skin conditions. We revised question 3, which is not on the slide, just to reflect the HERC guidance. And then question 7, we added specific drugs that need to be stepped through for approval. So that is the topical corticosteroids or tacrolimus. For the treatment of severe atopic dermatitis. And then we added Ruxo Light Nib to the note there that those are drugs that are indicated for mild to moderate AD. So there has to be more of an assessment in terms of whether or not the patient will meet the criteria for that. And that's all the changes we had for the topical agents. Next slide, please. The next set of PA criteria begins on page 175. And as I mentioned, this was previously called biologics for severe asthma. Now we're going to call it targeted immune modulators. We're trying to use the term targeted immune modulators instead of biologics because the class is ever expanding beyond interleukin inhibitors to JAK inhibitors and some of the TNF antagonists. And then we added mild to moderate atopic dermatitis in the goals for this because we're expanding it to include not only asthma, but atopic dermatitis. I didn't go into the disease details, but as you know, asthma and atopic dermatitis overlap a lot. So that's why a lot of these drugs might have dual indications. And then we clarified which drugs would require PA. And then another note saying that this does not apply to the topical agents. Next slide, please. Some other changes were to revise table 2. I'm just going to talk about atopic dermatitis. We'll talk about asthma in just a minute. So we're going to add Aprocytinib and Trello as FDA approved atopic dermatitis therapies to that table 2. And then we added a new table, table 3, which describes the Aprocytinib dosing adjustments or contraindications. The reason we did that was to help reduce the number of steps that we had in the Aprocytinib assessment. Next slide, please. So this is all new. That's why it's all in red. So this is the assessment for the request for Aprocytinib. So we want to make sure first that they've gotten baseline labs. And then there's a note here about if the labs are abnormal, if they're abnormally low, that therapy should not be started. It's the Aprocytinib is contraindicated to be co-administered with other immunosuppressive agents. So we're asking that question in 10. And then question 11, we ask if they have renal or hepatic impairment and has the prescribed dose been adjusted as described in table 3. And then finally, question 12, I put some specific drugs that are contraindicated to be co-administered because we don't always know what CYP2C19 inhibitors are, or CYP2C9 inhibitors, or the inducers, because the dose needs to be adjusted. So that's the final assessment for Aprocytinib. Next slide, please. Then the Trello Mad Assessment will start with question 1 or 2, where we ask, what's the diagnosis and is it funded? And then, like I mentioned, we're adding it to table 3. What I wanted to ask the P&T committee for their input on is previously when we reviewed dupilumab, one of the P&T committee members had suggested that we add question 5 about requesting a concurrent prescription of EpiPen because of the risk of delayed hypersensitivity. So I wanted to ask the P&T committee if you felt like including this for tralokinumab, which is an IL-13 inhibitor and does have the possible warning for delayed hypersensitivity. Do you feel like having question 5 is appropriate for tralokinumab? I can open it to comments now, or we can wait until I go through all the PA criteria. Hearing no comments, I think we'll wait till we get to the final discussion. Okay, the next question is on the next slide. So our standard step-through therapy for any of the targeted immune modulators is to try the topical corticosteroids and the topical calcineurin inhibitors. And then based on the clinical guidelines, we also ask if they step through oral immunomodulator therapy. If you recall, the FDA approved indication for tralokinumab is for patients that have only failed topical therapy. So I wanted the P&T committee to address, do you feel like having the step through for the oral immunomodulators is appropriate for tralokinumab? Do you feel like we should leave that, or should we put in separate criteria where we just look at the topical agents based on what the FDA approval is? So I will, hopefully you will address that when we get to the questions for from the P&T committee. We'll go to the renewal criteria for this this set of PA criteria. So all we did was take out dupilumab because that was the only drug that had the approval for atopic dermatitis prior to this, and replace it with targeted immune therapy. All right, last set of PA criteria is on the next slide. So what we're doing with the targeted immune modulators for autoimmune conditions, like I mentioned previously, we're adding Eupatacytinib, the indication for atopic dermatitis, we're adding it to that big table that has all the indications for all the targeted immune modulators. There have been some additional expanded approvals for those 6 drugs that are listed there. We will bring this back for review probably in October. That's generally when we review the targeted immune modulators. But for now, we just wanted to add these approved indications to the table. So if Gainwell reviewers get a request for one of these drugs with this indication, their PA criteria will be complete. We could go to the next slide, please. All we're doing here is just updating the HERT guidance to add FACE as an assessment. Next slide, please. What we're doing with this set of questions here, question 12 through 14, is we're just taking the atopic dermatitis criteria that we used for the severe asthma, and we're inserting it into the targeted immune modulators for the autoimmune conditions, and just to do the assessment of, is it for severe atopic dermatitis? Do they have functional impairment? And then have they stepped through the drugs that we asked them to step through for Eupatacytinib? And then the final change for this is on the next slide, and we'll be just asking for the renewal criteria. If it's for atopic dermatitis, if it is for atopic dermatitis, has the patient noticed some improvement in their atopic dermatitis using one of these assessments, which are outlined in the HERT guidance as well. So with that, I will open it to questions from the P&T committee.
Hey, Deanna, can you maybe ask, so there was really 2 questions that you had for the P&T committee, correct?
That's
one about
correct.
the EpiPen, and what's the other one? Can you maybe just throw those back out so that
I sure can. So
Thank
the
you.
first one is, do you feel like using, having the EpiPen requirement? Thank you, Sarah, you are so good. Is that necessary for tralokinumab? It's not in the labeling. It's not in the label for dupilumab either. I believe Kathy Zierong was the one that brought this forward. Based on the warnings and precautions, she thought it would be prudent to make sure the patient had an EpiPen in case they do have a reaction to this drug after they take it.
And is the risk comparable?
I would say yes. Dupilumab is a different, it works on a different interleukin inhibitor, but at the end of the day, they wind up impacting the same cytokines. So I would say that they are comparable, and I think it's prudent to keep this in here, but I wanted to get your feedback on that.
I vote yes then. I mean, what does everybody else think? Because I would say if there's a comparable risk, then we should keep them consistent.
One of the problems is we only have 52 weeks of adverse effect data with tralokinumab. That's the longest the study has been. So because it is so new, we don't have a lot of long-term safety data. So that might be another reason to consider that, because as you know, a lot of the adverse effects come to light in post-marketing surveillance.
And Deanna, just to confirm, that would be provider or prescriber attestation, not necessarily needing claims history, as they could have one.
Exactly. That's a great point, Roger.
Yeah, I would vote to leave it in unless, I mean, I just, it feels to me like, again, if the risk is comparable, then we should do the same for both agents.
And I think it's just a safety precaution.
Yeah. Right.
And then the next question is on the next slide. So for tralokinumab, the FDA approval is failure of topical agents. I have a sneaking suspicion that we are going to see new guidelines come forward in the next year where they might move the biologics or the targeted immune modulators up in terms of the step therapy. But for now, all the guidance recommends trying an oral immune modulator. All of these are prescribed off-label for atopic dermatitis. So the question is, should we keep this step-through therapy for the oral immunomodulator for tralokinumab, or should we remove it because of the FDA-approved indication, which is just for failure of topical therapy?
You said that, but current guidelines say to do the oral.
Right, and remember the guidelines are from 2004 and 2014. Yeah. So they're very old. So a lot of the targeted immune modulators were not available. And I believe the American Academy of Dermatology is probably working on updated guidance, because we have 4 new drugs that we've just looked at for atopic dermatitis, in addition to dupilumab. So I think there's going to be some discussion about what's the place in therapy for these newer agents. And the evidence that we have for the oral immunomodulators is very dated, and it's based on very small studies. Right. I think the targeted immune modulator data that we have is more robust. Both classes of drugs are immunosuppressant. So they both have the adverse effects of causing immunosuppression. So that has to be considered as well. If that gives you any more information to help make your decision about should we have step through for the oral immunomodulators for tralokinumab.
What does the rest of the committee think? I don't have any, I'm not sure I have a strong feeling either way.
This is the current PA criteria we use for dupilumab. But dupilumab has a different FDA approval.
Right.
We do have 5 people signed up for public comment for this topic. Do we want to let them provide their
That sounds great.
comments?
Yeah, that's a good
And then we'll
idea.
revisit some of these questions.
That sounds perfect.
All right. Just to kind of get people staged to be prepared, I will be making you a co-host so you're able to unmute yourself. Again, the 5 people in order. I apologize if I get your name mispronounced, but Valerie Ying, Rochelle Yang, Charles Levin, Victoria Romo Letourneau, and Thume Duong. That's the order of people. Valerie, I have made you a co-host. Are you able to unmute your line?
Yes, I have unmuted, Roger. Can you hear me okay?
Can hear you loud and clear, and the floor is yours.
Thanks, Roger. And thank you, Deanna, for such a nice and incredibly thorough review. So good afternoon, everyone. I'm Valerie Ng, Medical Outcomes Liaison at Leo Pharma. Really glad to have this opportunity to be with you virtually and share with you information on Adbry. As Deanna mentioned earlier, Adbry or tralokinumab was approved by the FDA on December 27th of last year. It is a first-in-class human high-affinity monoclonal antibody that specifically neutralizes interleukin-13 or IL-13. IL-13 has been shown to be a key cytokine driving inflammation in atopic dermatitis or AD skin. And Adbry is indicated for the treatment of moderate to severe AD in adult patients whose disease is not adequately controlled with topical prescription therapies, or when those therapies are not advisable. It can also be used with or without topical corticosteroids. The recommended dosage is an initial dose of 600 milligrams via subcutaneous injection, followed by 300 milligrams every other week. A dosage of 300 milligrams every 4 weeks or monthly may be considered for patients below 100 kilograms who achieve clear or almost clear skin after 16 weeks of treatment. Safety and efficacy profile of Adbry has also been established in the extra clinical program for adults with moderate to severe AD. And as a matter of fact, we do have the Extend clinical trial. It's an ongoing 5-year trial, and we do have safety and efficacy results through 3.5 years now. Efficacy was assessed in over 1,900 adult patients in the 3 pivotal trials where Adbry demonstrated superiority over placebo for the primary and secondary endpoints of the IJ01, EZ75, and worst daily pruritus score at week 16, and maintained those responses through week 32 and week 52. The most common adverse events, as Deanna mentioned earlier, were upper respiratory tract infections, conjunctivitis, injection site reactions, and eosinophilia, most of which were non-serious and mild or moderate in severity. And overall, Adbry represents a new therapeutic option in this treatment paradigm for moderate to severe AD in adult patients. And with that option to provide a maintenance dosing of every 4 weeks for eligible patients, their chronic disease may be managed with fewer doses. Therefore, we'd like to ask the committee to consider adding Adbry to the PDL as a preferred product for adult patients suffering from moderate to severe AD who had an inadequate response to topical prescription therapies. One last thing I'd like to note was on the anaphylaxis, which is 2 days after the, in this case, tralokinumab was given. That was not seen in the Adbry trials for atopic dermatitis. However, that was seen in the asthma trial, which obviously is not approved for it, it's not indicated for it, but it has to be added to the label. Nonetheless, I'd like to see if there are any questions I can help answer.
Thank you, Valerie. Any questions? All right, thank you. Next up, we have Rochelle Yang with Teva Pharmaceuticals. Maybe it's Teva.
Yeah, no worries. Hi, my name is Rochelle Yang. I'm with Field Medical Affairs at Teva Pharmaceuticals. My public comment was not related to atopic dermatitis, but actually for the asthma biologics, specifically rislizumab or Syncare. But if there is no questions on that, I can go ahead and cede my time back to the committee. Thank you.
Appreciate that, Rochelle. Any questions from the committee? All right, hearing none, you gave me no time to find my next commenter. All right, well, next we have Charles Levan with AbbVie. Charles, are you able to unmute your line?
Yeah, I'm here, Roger. Can you hear me?
Hear you loud and clear. The floor is yours.
Thanks. Hi, everyone. My name is Charlie Levin with AbbVie Medical Affairs. Thanks for allowing me a few minutes to provide information on Eupatacytinib with the brand name Rinvoq, which is an oral JAK inhibitor, which has been approved to treat patients with rheumatoid arthritis, psoriatic arthritis, and most recently atopic dermatitis, ulcerative colitis, and ankylosing spondylitis. My focus today, however, is on atopic dermatitis, where Eupatacytinib has been FDA approved to treat adults and adolescents patients 12 years and older. So atopic dermatitis is a type of eczema that is chronic, highly pruritic, and characterized by an unrelenting itch that can have debilitating physical and psychological burden on the patients. Rinvoq has differentiated itself from other medications currently available for the treatment of atopic dermatitis. Rinvoq at both 15 and 30 milligram doses met all primary and secondary endpoints in 3 16-week placebo-controlled pivotal trials. Those are Measure Up 1 and 2, which looked at monotherapy treatment, and Add Up, which was a trial that evaluated Rinvoq in combination with topical corticosteroids. So in these studies, the investigators noted a rapid onset of action. Over 2/3 of patients saw a statistically significant 75% improvement in skin symptoms after 16 weeks, and a significant reduction in itch was seen as early as day 2 with the Rinvoq 30 milligram, and as early as day 3 with 15 milligrams. In all 3 studies, Rinvoq demonstrated disease control for adults and adolescents throughout the double-blind period, with and without the use of topical corticosteroids. The safety in Eupatacytinib is well studied with clinical trial experience in over 9,900 patients since 2012 across 5 approved indications. The overall safety profile is consistent for Eupatacytinib across these indications. The most common adverse events seen in the AD trials were upper respiratory tract infection, apnea, headache, and nasopharyngitis. AbbVie, of course, will continue to observe patients and determine the long-term safety with Eupatacytinib across all of these indications. This has been a short review, of course, so please refer to the prescribing information for further efficacy and safety information. I'd just like to respectfully ask the committee to confirm the proposed criteria, which would allow access to Rinvoq and other medications for patients suffering from atopic dermatitis. And then just one last item, in that targeted immunomodulators for autoimmune conditions, Deanna had a list of other approvals or expanded indications that were not necessarily relevant to atopic dermatitis. But I just wanted to mention that ulcerative colitis and ankylosing spondylitis should also be included there for Eupatacytinib, as they were approved recently in March and April, respectively, for ulcerative colitis and ankylosing spondylitis. So thank you for your time, and I'll take any questions.
Thank you, Charlie. Any questions for Charlie? All right. And I was corrected. We still have more for you to present, right, Deanna, with the asthma?
That is correct.
Sorry, I jumped the gun here. So
No worries.
Rochelle will give you another chance in a moment. Deanna, what were you going to say?
I said that's correct. And I just wanted to thank Charles. It's hard to keep up with these ever expanding indications. So we will make sure we add, we have UC added to the table for Eupatacytinib, but we don't have ankylosing spondylitis. So that's the one we need to add, correct?
Correct. Yep. Thank you. So yeah, we're approved for 5 indications now. And I think
Yeah, we
if
have
UC is on
psoriatic.
there, then it's AS,
Yeah.
yes.
Yeah, we have psoriatic arthritis, rheumatoid arthritis, UC, and then atopic dermatitis. So we'll just need to add ankylosing. And what's the age range for ankylosing spondylitis?
I believe it's just for adults, but I'll double check and send you a note.
I can look it up. I thought you might know off the top of your head. That's okay.
Thank you.
All right, thank you, Charlie. Next, we have Victoria Romo Latorno. Are you able to unmute your line?
I'm unmuted. Can you hear me?
You're loud and clear. The floor is yours.
Fantastic. And thank you. You did an amazing job in pronouncing my name. So good afternoon to the committee members. My name indeed is Victoria Romo Latorno. I'm a pharmacist and field medical director at Pfizer. And thank you for allowing me to provide a very brief medical presentation on Aprocytinib, brand name, as you heard, Sublingual, which is indeed a JAK inhibitor indicated for the treatment of adults with refractory, moderate to severe atopic dermatitis, whose disease is not adequately controlled with other systemic products, including biologics, or when it is deemed by a clinician that the use of these therapies is inadvisable. It was FDA approved earlier this year. And given the time frame here is brief, please do refer to Sublingual's full prescribing information. I'll outline a few key points today. There is indeed a boxed class warning for the JAK inhibitors for serious infections, mortality, malignancy, major adverse cardiovascular events, and thrombosis. These events have occurred in a trial involving another JAK inhibitor in rheumatoid arthritis patients. Note that Sublingual is not approved for use in rheumatoid arthritis patients. Sublingual is contraindicated in patients taking antiplatelet therapies, except for low-dose aspirin, during the first 3 months of treatment. Some of the most common adverse reactions include nasopharyngitis, nausea, headache, and acne. With regards to the efficacy data, the efficacy of Sublingual as monotherapy and in combination with background topical corticosteroids was evaluated in 3 randomized double-blind placebo-controlled trials in over 1,600 subjects, 12 years of age and older, with moderate to severe atopic dermatitis. In the 2 monotherapy trials and the combination trial, the percentage of patients with an investigator's global assessment score of clear, a score of 0, or almost clear, a score of 1, and at least a 75% improvement in the eczema area and severity index was statistically higher in both Aprocytinib arms compared to placebo. The proportion of subjects that achieved an itch improvement in the peak pruritus numerical rating scale at week 2 was higher in subjects treated with Sublingual in both dose arms compared to placebo in all 3 of these trials. Sublingual's recommended dosage is 100 milligrams orally once daily. 200 milligrams is recommended for those not responding to the 100 milligram dose, and Sublingual can be used with or without topical corticosteroids. So in conclusion, atopic dermatitis continues to have a high unmet medical need, and adding an orally administered medication will offer an additional treatment option for patients with moderate to severe atopic dermatitis. Based on the efficacy and safety of Sublingual, I ask that you consider adding Sublingual to the PDL. So thank you to the committee for your time today, and I indeed would be happy to respond to any questions you may have.
Thank you, Victoria. Any questions for Victoria? And again, understanding we're still going to go back and do some more discussions about asthma. We have Thume Duong from Sanofi. You've signed up for dupilumab for both indications. Do you wish to provide comment now, or would you like to wait and then provide your comment?
Is it okay? And I don't know if I can ask and lobby for this, but since my presentation was timed for 3 minutes and included both asthma as well as AD, can I ask for a little more time when I do my presentation so I can address both and make it efficient for everybody?
No, actually, we'd like to keep you to 3 minutes for the one drug, but I'll hold you off and you can do it after Deanna finishes her next presentation.
Okay, I will try to speed it along then. So my name is Thume Duong, and I'm with the Medical Value and Outcomes team at Sanofi. Today, I will provide key clinical highlights for Dupixent or dupilumab, specific to its approved indications in atopic dermatitis, which I'll be referring to as AD, as well as asthma. If you can please refer to the full PI for additional details. Now, dupilumab is a fully human monoclonal antibody that binds to the IL-4 receptor alpha, inhibiting IL-4 and IL-13 cytokine pathways associated with type 2 inflammation. Dupilumab has been on the U.S. market for over 5 years with 4 unique indications, including AD, asthma, chronic rhinosinusitis with nasal polyps, and more recently, eosinophilic esophagitis. Please note that these are all type 2 inflammatory conditions. In addition to the clinical trial data, dupilumab has both long-term and real-world data showing sustained efficacy and safety for patients with AD, asthma, and nasal polyposis with no new or significant post-marketing safety concerns. Now, starting off with AD, dupilumab is indicating the treatment of patients 6 years of age or older, which is unique, with moderate to severe AD whose disease is not adequately controlled with topical prescription therapies or when those therapies are not advisable. Dupilumab has 4 years plus of long-term data from the AD OLE trial showing adults with moderate severe AD experienced sustained improvements in skin lesion severity, AD symptoms, and quality of life over the 148 treatment week period. Dupilumab has real-world data from the RELIEVE AD study showing that dupilumab was associated with improvements in AD flares, AD symptoms, AD control, treatment satisfaction, and treatment burden. Now, from a safety perspective, the most common adverse reactions are injection site reactions, conjunctivitis, and blepharitis. Furthermore, dupilumab is not classified as an immunosuppressant by the FDA and the WHO. Studies have supported that these patients taking dupilumab have no increased risk of infection. Now, lastly, the ICER 2021 AD report concluded that dupilumab is associated with favorable long-term cost effectiveness compared with the JAK inhibitors Eupatacytinib, Aprocytinib, and Baricitinib, and the IL-13 inhibitor Trello in adults with moderate to severe AD. Now, with regards to asthma, dupilumab is indicated as an add-on maintenance treatment of patients 6 years of age or older with moderate to severe asthma, characterized by an eosinophilic phenotype or with OCS-dependent asthma. Dupilumab has long-term data from the TRAVERSE OLE trials showing sustained efficacy in exacerbation rates, lung function, asthma control, and quality of life up to 148 weeks in non-OCS-dependent patients with moderate to severe eosinophilic asthma. The OCS-sparing study, VENTURE, also saw sustained OCS reductions while maintaining asthma control and improving lung function in OCS-dependent patients over 48 to 96 weeks. Now, from a safety perspective, the most common adverse reactions are injection site reactions or pharyngeal pain and eosinophilia. As discussed, AD and asthma are considered to be type 2 inflammatory conditions in a pooled study involving 4 AD GP studies involving over 2,400 adults with moderate severe AD and asthma, as well as nasal polyposis. Dupilumab shows significant improvements in AD severity and itch, asthma control, and sinonasal symptoms. So based upon the long-standing and long-term efficacy and safety studies, we would like to request that dupilumab be maintained on the preferred drug listing, and if possible, to remove the oral immunomodulatory or oral immunosuppressant requirements, so azathioprine, cyclosporine, methotrexate, etc., as a criteria for approval. Thank you very much.
Thank you very much. Any questions? All right, hearing none. Again, I got thrown off by the slide with public comment. This is just a monster topic with multiple Venn diagram indications. So Deanna, we're going to turn it back to you.
I would suggest that we take each set of PA criteria separately in case there's any suggestions for changes from the committee.
Okay, so you want to go these recommendations now?
Yeah, so the first one, do you agree, Stacy? Go take it away, Stacy.
Oh, no, totally fine. Yep, however you want to do it.
So does the P&T committee agree that revising all the PA criteria to add the HERC guidance is appropriate? By the way, the HERC guidance also states, it is listed in the packet. It's in Appendix 4. If you want to look at the HERC guidance, I meant to mention that. They talk about what therapies should be used, and HERC doesn't usually talk about what is first or second line, but if you look at page 168, the HERC guidance right now recommends for atopic dermatitis that oral immunomodulators be used, and that's based on the clinical guidelines. Just to make it more complex.
All right, so we're going to take the recommendations that are in front of us here on the slide. I am not going to read through those and save a little bit of time. Questions for Deanna or a motion to approve?
Move to approve.
Thank you, Robin.
Second.
All those in favor?
Aye.
Aye.
Aye. Aye.
Opposed? Abstain? All right. Oh, thank you, Deanna. That was a lot.
Thank you. And I appreciate your patience as I tried to speed through all those drugs. I knew we had a lot of public comment. The next set of class update is on page 196. So we do have a new asthma drug. So this, if we go to the next slide, please. Table 1 on page 201 summarizes the drugs that we will be discussing for this class. So just as a reminder, we provide coverage for the 4 targeted immune modulators that are approved for eosinophilic asthma. So that includes benralizumab, dupilumab, mepolizumab, and reslizumab. And then we also have an additional biologic, omalizumab, which is approved for patients with severe allergic asthma. So the PDL status is on page 215. We do require a PA for all of these drugs to make sure that they're being used in the appropriate indication. Next slide, please. So since the last review, there's one systematic review that looked at the targeted immune modulators for treating chronic rhinosinusitis, and then 4 high-quality guidelines were published. The 4 high-quality guidelines are really what helped modify our PA criteria to be more in line with current guidance. So I'm going to try to run through this quickly because we're running over time. So next slide, please. So in the systematic review, they basically looked at the 3 drugs that have approval for chronic sinusitis with nasal polyps. And we had good evidence that dupilumab is effective in that indication, and that omalizumab may improve quality of life, but there's no evidence regarding the impact of omalizumab on disease severity. Next slide, please. The GINA guidelines, I think we talked about those when we talked about asthma, when Kathy talked about asthma. The big difference with the GINA guidelines was that we now have additional guidance for the management of severe asthma in adolescents and adults. So the recommendation is to consider adding a monoclonal antibody for patients that have poor control and are already maintained on high-dose inhaled corticosteroids, if they have eosinophilic or allergic biomarkers, or if they need maintenance oral corticosteroids. And then there's recommendation about which biomarkers should be looked at. So previously we just looked at serum immune globulin E, and the baseline eosinophil cell counts. But now we're also looking at the fractional exhaled nitric oxide. So that's in all of the guidelines. Next set of guidelines is from NICE. And sorry, I went ahead of myself. I thought I had NICE, but no, CADITH. Okay, so CADITH put together a review of dupilumab. Their guidance about using dupilumab in severe asthma is to very similar to GINA, using it for inadequate asthma control despite the use of a high-dose corticosteroid inhaler and 1 or more additional asthma controllers. And then they also specified if the eosinophil count is greater than 150 cells per microliter, or if they're corticosteroid dependent. And then they also recommend a baseline assessment. Okay, the next slide is the NICE guidance. So NICE has guidance for mepolizumab in treating severe eosinophilic asthma. And their baseline for mepolizumab is 300 cells per microliter. And that's if patients have had 4 exacerbations needing oral corticosteroids in the previous 12 months, or if they've been using continuous oral corticosteroids at the equivalent of prednisolone 5 milligrams per day or more over the previous 6 months, or if they have a higher blood eosinophil count of 400 cells per microliter and 3 exacerbations. Next slide, please. And then there's similar guidance about using dupilumab. And again, this kind of reflects what we've seen with Cadith and with Gina in using dupilumab for severe asthma. If their blood eosinophil count is greater than 150 cells per microliter. NICE has added the inhaled nitric oxide, and then the number of exacerbations. Mepolizumab, resilizumab, and benralizumab were available before dupilumab in the UK. So in their criteria, they recommend that people start with those drugs, I think because they have more experience with those before dupilumab got the approval for severe asthma. Next slide. Please, thank you. So we do have a new drug. It's a unique drug, tezepelumab. It binds to a cytokine called thymic stromal lymphopoietin, or TSLP, which works in the upstream inflammatory cascade. All of our other targeted immune modulators work downstream. So this is unique, and it has a unique indication. So it's indicated as maintenance treatment for patients 12 years and older that have severe asthma. So note that there's no quantification for eosinophils. It's just patients that have severe asthma that's poorly controlled. Next slide, please. So there was 2 trials that were submitted to the FDA for approval. We don't usually present evidence from phase 2 trials. We did for this because they use the same outcome as the phase 3 trial, which was the annualized asthma exacerbation rate at week 52. So you can see the pathway trial was a dose-finding phase 2 randomized controlled trial, and the Navigator trial was a multi-center placebo-controlled phase 3 randomized controlled trial. They settled on the tepezimab 200 milligrams subcutaneous every 4 weeks after looking at the results from the phase 2 pathway trial. A lot more adults and adolescents were enrolled in the Navigator trial. I do want to point out only 8% of the total population were adolescents that were enrolled in this trial, but the FDA extrapolated the evidence from the adults to get the approval for adolescents that are age 12 and older. In both of these studies, the patients had to have at least 2 asthma exacerbations in the last 12 months. In the phase 3 trial, they did add that they had to have been using an inhaled corticosteroid or a controller medicine. Next slide, please. So the clinical efficacy, you can see in the dose finding trial, all the doses were effective at reducing the rate of asthma exacerbations. And that's why they settled on the number 2, the 210 milligrams sub-Q, Q4 weeks, because it had the highest relative reduction versus placebo. And then in the phase 3 trial, they looked at the overall population, and you can see that with tepezimab, the annualized asthma exacerbation rate was 0.93 compared to 2.1 with placebo. So that was statistically significant. They also wanted to look at a subpopulation of patients with eosinophils less than 300 cells per microliter. And they also showed a significant reduction in the asthma exacerbation rate. Next slide, please. This is just a summary of the trial limitations. So the pathway trial was in primarily white female adults. So that limits the extrapolation to ethnically diverse populations. As I mentioned, the Navigator trial was not powered to demonstrate significance in adolescents, but the FDA looked at the adult data and extrapolated to the adolescents. They did have exclusion criteria. Smokers were not part of this, so that makes it difficult to expand this information to people that are smokers. And we don't have safety data beyond 52 weeks that's published, although a long-term extension study is currently underway. Next slide, please. Clinical safety, the adverse effects that were observed with tepezimab were very similar to placebo, pharyngitis, arthralgia, and back pain. This was in the pooled safety population from all of the studies that they looked at for tepezimab. Next slide, please. So the recommendations are to add tepezimab injection to the PA criteria for the target immune modulators for severe asthma and atopic dermatitis, and maintain it as non-preferred on the PDL. And then, as I mentioned, to align with the current guidelines, we'd like to revise the PA criteria to reduce the threshold for blood eosinophils to 150 cells per microliter for the monoclonal antibodies that are prescribed for eosinophilic asthma, update the definition of what a severe asthma exacerbation is, and then include the use of oral corticosteroids in the asthma exacerbation criteria. And we will review the cost and exec session. So this is table 2. As you can see, we added a third type of asthma. We already had eosinophilic asthma and moderate to severe allergic asthma. Now we've added the difficult to treat severe asthma for tepezimab, and we added the definition of what difficult to treat severe asthma is down there with the asterisk. Next slide, please. This is the we added this table to make the review of the PA criteria easier. Instead of asking questions, we just said refer to table 4. So basically, this is a summary of all of the targeted immune modulators that are used for severe asthma, the brand name, and then any dosing requirements based on what the age range is. Next slide, please. So we're going to revise question 20 to align with the recently published guidance. So everything in red is new. Before, we just had, have they been hospitalized or had an ED visit while they've been on an inhaled corticosteroid and another controller. Now we've added having 4 exacerbations that requires systemic corticosteroids in the previous 12 months, or if they're taking corticosteroids at the equivalent prednisolone dose of 5 milligrams per day for the previous 6 months. Like I said, this aligns with the guidance that I went over super quickly. And then we want Gainwell, when they're doing their PA assessment, to document what specific criteria they're meeting. Next slide, please. And then we're adding a review of, is there a request for tepezimab? And then if it is, if they meet all the other criteria, we'll approve it. Question 25 is to look at the biomarkers. So we're adding the fractional exhaled nitric oxide greater than 25 parts per billion in the past 12 months in case the prescriber is assessing that particular biomarker instead of the eosinophil count. Next slide, please. And then for the renewal criteria, we're just adding asthma exacerbations that require an oral corticosteroid. And I think that's all we were doing to the renewal criteria. Next slide, please. Yep. So now we have more public comment. We had 2 people, is that correct?
That's correct. Any questions for Deanna on this section? Again, great work, Deanna, and I apologize for jumping the gun for the first section.
Oh, no worry. I've been trying to get through this as quickly as I possibly can, and I'm sorry if I'm not meeting that objective.
No questions for Deanna? All right, Rochelle Yang, Teva Pharmaceuticals, I'm going to go back to you as called upon you too soon. Are you able to unmute yourself?
Yeah, Roger, I am. And that was a very thorough review by Deanna. And if there's no questions on Rislizumab, I can actually go ahead and give the time back to the committee again.
Wow. Appreciate it. Any questions for Rochelle? Gold star. All right, let me see if I can work my buttons. And again, we had Tumei Thuong for Dupilumab. Generally, we do limit manufacture to 1 minute, but this is overlapping. And so, yep, we're willing to give you a brief minute of time. So the floor is yours.
Thank you so much, Roger. And again, the name is Tumei Thuong, and I'm with the Medical Value and Outcomes team with Sanofi. Really appreciate the flexibility for some additional time. And I was mentioning about Dupilumab, and this is more specific to asthma. I've already kind of discussed it with you previous. As you know, it's an add-on maintenance treatment for patients 6 years of age or older with moderate severe asthma, characterized by an eosinophilic phenotype or with OCS-dependent asthma. And note that this OCS indication is unique to Dupilumab. We also had already spoken about the long-term data from the TRAVERSE showing sustained efficacy and exacerbation rates, lung function, asthma control, and quality of life up to 148 weeks in patients who had moderate severe eosinophilic asthma. Now, what is new that I want to draw attention to is that there's real-world data and evidence with Dupilumab in a 12-month observational study of adults with severe asthma in Italy, where Dupilumab was associated with improvements in the incidence of exacerbation, lung function, and asthma control. And finally, to round this out, safety perspective, most common adverse reactions are injection site reactions, oropharyngeal pain, and eosinophilia. Thank you so much for the flexibility and the additional time. I appreciate it.
Thank you. Appreciate you being brief, but giving us the real world data. So any questions from the committee? All right, if we can get the recommendations back up for this section. Deanna, I didn't know if you wanted to lead this again.
It's a lot
I'm not going to attempt.
It's a lot simpler than what we just went through. Basically, we want to add Tepezimab to the targeted immune modulators for severe asthma and atopic dermatitis and maintain it as non-preferred. And then those changes that I went through in terms of assessing severe asthma. So updating the definition and then lowering the blood eosinophils to 150 cells per microliter, and then adding the use of the oral corticosteroids. And that's all based on the GINA, CADIF, and NICE guidance.
Questions for Deanna, or do we entertain a motion?
I move to approve.
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you. Good job, Deanna.
Oh, thank you. And then one more lit scan on vitiligo, but can I just cut to the chase? The biggest thing we did on the vitiligo, without going through all the slides so we can get to our other topics, is we just revised the prior PA criteria like I already showed you, and you already approved for all of the PA criteria that have atopic dermatitis. So you've already approved it. I don't really think we need to go through. The evidence for vitiligo is basically topical corticosteroids. Just trying to wrap that up in a nutshell real quick.
So do we need to vote on this again or no?
You've already approved it.
We do.
And, yeah. Okay.
Oh, well, no, go ahead, Deanna.
They've already reviewed it because I went through all those changes. The lit scan was just to have information about vitiligo. If you want to review it, you can, but we'll be talking about the topical steroids in exec session.
Now that I'm thoroughly confused, I think we're ready to move on. Great job. Try to keep my comments brief. We have two more topics. I don't know if we're gonna be able to get through both of them, but we will do the next one. If you're following in the packet, we're on page 245, the Mycobacterium agents, and we'll turn it over to Sarah Fletcher.
Thanks, Roger. Yes, I did a literature review for the Mycobacterium drugs. We can go to the next slide. This was a class review, and so this is a new PDL class that we're proposing, and it was just to review the evidence. And you'll see as I go through, because it's a new class, I had to do a lot of exclusions just because it's been around for so long, and there are a lot of high quality guidelines, and so I deferred to those instead of systematic reviews for the infections that are most commonly seen and treated with these drugs. So for the background, mycobacterium agents were most commonly used for tuberculosis, non-tubercular mycobacteria, which are things like Mycobacterium avium complex and M. abscessus. And those, as well as other things like leprosy, they have different resistance profiles and lots of different sites of infections. They're primarily pulmonary, but they can be basically anywhere. They're also generally reportable to the public health department. TB, any non-pulmonary NTB, those are reportable. The only assessment we've done in this class so far was for something called bedaquiline, and that was reviewed in 2014. It was made non-preferred because at the time efficacy was based on phase 2 studies, and it has a black box warning for increased risk of death. You can see the agents that are applicable for this class in table 2, but I just want to point out that pyridoxine, linezolid, azithromycin, clarithromycin, immediate release, levo, and moxie are all also used to treat these infections, but they're in different PDL classes and they are preferred. That's part of the reason we brought fluoroquinolones into the April meeting. And then the other rifamycin, so not rifampin, which is also called rifampicin, rifapentin, and rifabutin, but the other two are also in another class because they're indicated for things like traveler's diarrhea. So if we go to the next slide, the only 2 systematic reviews I really included were one for abdominal TB with a short course therapy of 6 months, or the standard course versus a longer course, and there's likely no difference in clinical cure rate between the longer and the more standard 6-month regimen. And then for brucellosis, which is also not the most common disease in the United States, but it can be imported with foods like cheeses. Rifampin, when compared to streptomycin, was found to have increased risk of treatment failure and a higher risk of relapse in the setting of doxycycline background therapy. But that difference went away when you do a subpopulation analysis for those over 40 years. And importantly, they didn't look at safety differences, and there are some pretty significant differences in safety and administration of these 2 drugs. So we go to the next slide. I've grouped all of the guidelines by what they're about rather than chronologically. So first off, I have the non-tubercular mycobacterium. There are 2 sets. One is from the British Thoracic Society, and it was for children older than 1 year and adults with pulmonary disease but without HIV. And then the second guideline, which was from a group of professional societies, is for adults without cystic fibrosis or HIV. And if you look in tables 3 and 4 in the packet, you can see all of the recommendations. And because they cover such a wide range of different bacteria, the general synopsis is that the therapy is tailored to the organism, the susceptibility profile, the severity of the illness. And for those bacteria that are susceptible, you can see the agents that are most commonly recommended. And I've bolded rifampin, isoniazid, and ethambutol because they're part of the class that we've proposed today. And overall, the certainty of evidence is pretty low because it's hard to study a disease that's as rare as some of those infections. So next slide. This is for latent tuberculosis. When patients are exposed to active tuberculosis, they may get active disease, they may clear it, or they may get a latent infection that could relapse later in life or often doesn't. But WHO and CDC both have recommended regimens for those with latent TB. And you can see there's differences between them as far as recommended and alternative. But in general, we're talking about treatment with isoniazid, rifampin, and rifapentin. And in the US, once weekly isoniazid and rifapentin, and then 4 months of daily rifampin, which is also called rifampicin, are the regimens that are recommended with strong strength of evidence and preferred for, you can see, HIV positive patients and HIV negative patients of various ages. Next slide. So these are the guidelines for drugs susceptible to tuberculosis. And there are, again, this one, there's 3 of them. So the American Thoracic Society, CDC, and IDSA in conjunction with other organizations, WHO and NICE. And a lot of the information in these guidelines focuses on the frequency of therapy, so daily versus thrice weekly, things like that. But in general, the recommendation is for daily therapy for continuation and intensive phase. And the preferred regimen that has been preferred for decades now is 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol, followed by a 4-month continuation phase of INH and rifampin. Next slide. And then I wanted to note that both WHO and CDC issued statements of consideration recently based on the evidence from one new study. The study will be incorporated and graded in the next set of guidelines, but you can see the details of it in Table 11. It's called Study 31, and it was NIH funded. It was an open label non-inferiority trial of 2,500 patients all across the world. And they tested a 4-month treatment containing rifampicin, moxifloxacin, isoniazid, and pyrazinamide compared to that standard 6-month regimen that we're using. And the outpoint was for non-inferiority for tuberculosis-free survival at 12 months. And you can see there's just a 1% difference in unfavorable outcomes, so 15.5% versus 14.6% unfavorable at the end of the year, and that did meet non-inferiority criteria. I do want to note that this was specifically for pulmonary TB patients who were over 12, and for patients with HIV, they were on efavirenz-based therapy, or they were changed to an efavirenz-based regimen for the duration of the treatment period. The next slide. Finally, drug-resistant tuberculosis, which there's some information in the background defining what that is, but MDR TB is TB that's resistant to rifampin and isoniazid. It's not that common in the United States, and it can be more resistance, like with extended resistance that also includes fluoroquinolones or injectable agents like amikacin. In general, the treatment courses for this are very long. You're using 5 to 6 agents for up to 2 years or so. And the 2 different guidelines, which did share lit scans and worked together, they have strong recommendations for bedaquiline as well as moxifloxacin levo, and then for WHO linezolid as well. And those are in tables 8 and 9 in your packet. And I've bolded bedaquiline because it's part of the proposed drug group that we're looking at today. Next, all of these agents, there's actually quite a lot of severe side effects, particularly with hepatitis, but the only black box warnings that I did find were for bedaquiline from increased risk of death, and then isoniazid for sometimes fatal hepatitis. And the next slide. I broke these recommendations down into a lot of different steps, but most of them are based off of clinical evidence. So the recommendations that I'm bringing forth are to make a new drug class based on Table 2 for drug therapies called mycobacterium agents. I'd like to change bedaquiline status to preferred, given that it has strong recommendations for use in drug-resistant TB. I'd like to make rifampin and isoniazid preferred because they're components of first-line treatment regimens for drug-susceptible TB and for latent TB. Pyrazinamide and ethambutol, based on clinical evidence, be preferred as components of first-line treatment for drug-susceptible TB. And then rifampicin is an agent that's a first-line treatment for latent TB, and it's part of that alternative regimen for pulmonary TB. And so I've recommended all of those based off of clinical evidence. I do want to give consideration that all agents in this class be preferred to prevent barriers to care, particularly because most of the infections that these would be treating, they are reportable to the health department, and some of them are much longer than 6 months, and the non-preferred drug PA does expire at 6 months and have to be renewed. And we are looking at costs in executive session. And then finally, any new drug agents or formulations would become non-preferred until reviewed if anything new comes out. So made it as quick as I could, and I know we do have public comment for at least one person, but I'm happy to take questions.
Did a great job. Any questions for Sarah? All right, we do have public comment. I wanted to remind the committee that I sent you some written testimony from Dr. Kevin Winthrop. He's a professor of infectious disease and works with public health. He's from OHSU. So I sent that to you earlier in the day, and that's also posted as written comments on our website. And then again, Heidi Bem, did I say that, or is it Beam or Bem?
It's Bem, it's okay.
Okay, and we can hear you loud and clear. So with that, you have the floor is yours to address the committee.
Okay, great. Good afternoon. My name is Heidi Bem. I'm a registered nurse with a master's degree in public health. I've been the TB nurse consultant and TB controller for Oregon Health Authority for the past 14 years. I'm also faculty and a warm line consultant for the Curry International TB Center in San Francisco and current president of the National TB Controllers Association. So I support the recommended change to the mycobacterium drugs used to treat latent TB infection and TB disease to a preferred status. The medications used to treat TB that are listed as preferred status are all recommended by the CDC and WHO for the treatment of TB disease or LTBI. In order to eliminate TB in Oregon, it is important we increase the uptake by medical providers for these shorter course regimens for treating TB disease or LTBI, especially treatment for LTBI. By making it easier for providers to order rifapentine for their patients using the 12-dose INH rifapentine once-weekly regimen called 3HP, we may see it prescribed more often. Also, rifapentine and moxifloxacin are needed for the new 4-month regimen for TB disease, which is called HPMZ. In the past, most people with TB disease were treated for 6 to 9 months. Utilizing this regimen may decrease the burden on the patient and also the local public health authority, since less time will be required on directly observed therapy and also on case management by public health. Finally, changing the drugs used to treat multi-drug TB, such as bedaquiline, to preferred status will decrease barriers to getting patients on an appropriate regimen as quickly as possible, thus potentially minimizing the spread of MDR-TB, time spent in home isolation by the patient, and decreasing the severity of illness. So thank you for your time today. That's it.
Thank you very much, Heidi. Any questions for Heidi? All right, bring the recommendations back up. Sarah, I'll let you take the lead.
Sure. I have a recommendation that we create a new PDL class that we change. I pronounced it incorrectly earlier, but bedaquiline, rifampin, isoniazid, pyrazidamide, ethambutol, and rifapentine preferred based on clinical evidence. And then I asked the committee to consider making all of the other agents preferred to prevent barriers to care.
Any questions? And if not, need a motion.
Roger, do we need to decide on this making all other agents preferred before we move forward?
Let's hold off on that one. That's
defer it until executive session, but that is the recommendation.
Do we have a motion?
Lots of recommendations, but is there a motion?
I'd like to table this until after executive session.
The making all the agents or the other recommendations as well?
Well, just yeah, the whole thing, because it seems like all of it needs to sort of be considered together at one time.
I appreciate that. We'll do that. So along those lines, we have one more topic on the agenda, but I wanted to do a courtesy question for the committee. We do have, a handful, over a half a dozen classes to go over an exec, which means we might go 10 to 15 minutes over. Are you all available to stay on that long so that we ensure that we have a quorum?
Shoot, I'm not. This is Robin.
Okay. Then we're going to defer I apologize, Kathy Centeno, for the short notice, the estrogen class, but we're going to have to go into exec session now. So I need to make, Sarah, one of your profiles, the host. All right. We are going to be making a breakout room, moving the committee in there and quickly go through the confidential pricing. I have a short blurb to read, but again, we will just the committee and staff go into exec session. We won't make any decisions, but we'll come back out into open session to make final recommendations. So the P&T committee will now meet in executive session for the purpose of the consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 1926602F or RS 4143561 and 2, which allows the committee to meet in executive session to review confidential drug pricing, including substantial cost differences between drugs in the same therapeutic class that's necessary for the committee to make final recommendations. Representatives of the news media and designated staff should be allowed to attend the executive session. All the members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to report on any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decisions will be made in exec session, and at the end will be open to open session. Thank you. All right, we are back into open session. We have a handful of recommendations to make for the committee. I'm going to start at the top down and take each one individually. All right, I've done a head count. Looks like we've got the quorum here. So starting at the top of the order for the ADHD, DUE, and DERP summary, after review and executive session, the recommendation is to make methylphenidate tablet ER, which is considered its generic preferred. Let's take these one at a time. So motion to approve.
So moved. So
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? All right.
For the diuretic literature scan, no changes are recommended for the PDL. Motion to approve.
Approve.
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain?
Great. For the TIMS and the asthma and drugs for inflammatory skin conditions, no changes for the inflammatory skin condition. TIMS or autoimmune classes or TIMS for severe asthma or dermatitis. Make topical steroid products, betamethasone, propylene glycol cream, clobetasol propionate solution, desoxymetasone cream, and hydrocortisone cream products that have utilization all preferred.
So moved.
Motion?
So moved.
Second.
Second?
All those in favor?
Aye.
Aye.
Opposed? Abstain?
And finally, for the mycobacterium agents, after review of the recommendations are made actually in an open session and looking at some of the costs and the regimens, recommendation is to remove PA and PDL for bedaquiline and to keep all the agents open access.
So moved.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? All right.
Committee
Thanks,
members,
everybody.
thank you very much. Next meeting is August 4th. Thank you for your volunteer and all your work. That's it. I
Thank
know you have to
you
run.
for your expert staffing.
Thanks,
Oh.
everybody.
Yeah,
Thank
glad
you.
we got
Thank
a
you.
quorum finally. Great. Thank you.
Have a good day, everyone. Bye.
Bye.
Thanks.